Hey, check one, two. 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 Check one, two. Hey, check.
So are those flowers going down? Like the ones on the stairs?
Yes.
Yeah. Let me get rid of those. Bye.
So every remove all the flowers?
Yeah, but this isn't a wedding. It's a corporate event.
So party is on the stairs?
Absolutely. It looks terrible. It's a corporate event. You can't have a flowery stairs. So
Hey, check. Hey, check. Hey, check 1, 2. Hey, check 1, 2. Hey, check 1, 2. Check 1, 2. check 1 2 2 test check 1 2. Hey, check 1, 2. Hey, check 1, 2. test 1 2. Hey, check 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 1 2.
morning, everybody. Can I get you to have a seat, please? He's adjusting. Can you go? Well, yeah, I just don't know. That's good. There. Now you can hear me. That's good. Now can you hear me? Okay. Louder? How about I just dance? Good morning, everybody, and welcome both to our in-person guests here today in beautiful Calgary and to all our members joining us virtually from across the country to our inaugural CSCT Symposium. Today marks a significant milestone in the history of our organization. For the first time ever, we are hosting a national event dedicated to celebrating education, uniting cardiology technologist community across Canada. We are thrilled to share we have 145 guests joining us in person here today and an incredible 560 members participating virtually from coast to coast. Whether you're seated here in the room or tuning in from your home, your presence today is what makes this event truly meaningful. We are honored to welcome our 5 outstanding speakers who will bring a wealth of knowledge, experience, and insight from across the cardiology field. Their presence today will challenge, inspire, and help us grow as professionals. We are also proud to be joined by our sponsors and supporters from across the cardiology community, whose partnership has helped us bring this event to life. Their support underscores the vital role of CSCT members and CSCT members play in delivering high-quality cardiac care across Canada. This symposium is more than just an event. It is a celebration of who we are and how far we have come. It is a glimpse into the future of our profession, one that is more connected, more informed, and more empowered than we ever have been. Thank you for being a part of this incredible moment. We are excited to learn, connect with one another, and make memorable experiences. Whether you're here with us in Calgary or joining us afar, welcome to the first ever CSCT Symposium. Let's begin our day.
Just a reminder that to get credits for your CEUs, you will want to be logged into the app and check in for each session using the code CSCT. So I'm grateful to present the first presenter of the day. He is our honorary president for this year's symposium. Dr. Sandeep Argawa is a clinical professor of medicine at the University of Calgary and a committed cardiologist focused on comprehensive patient-centered cardiovascular care, emphasizing patient education for self-management and improved outcomes. His clinical expertise covers coronary artery disease and cardiac rehab, utilizing advanced diagnostics like cardiac MRI, CT, and echocardiography for individualized treatment. A member of the Libin Cardiovascular Institute since its founding, Dr. Argawa currently serves as the medical director of the Total Cardiology Rehabilitation Program, where his leadership has established Calgary as a national leader in cardiac rehabilitation. In recognition of his significant national contributions to cardiovascular prevention and rehabilitation, he was honored with the 2025 Terry Kavanaaugh Award by the Canadian Association of Cardiovascular Prevention and Rehabilitation. Please help me welcome Dr. Argawa, our honorary president for this year's CSCT Symposium, and enjoy the presentation on the topic of cardiac rehab.
Thank you. I was just commenting to your president that ever since COVID, I've never gone to so many conferences in my entire life. I remember for the first couple of years, I went to every CCC, every AHA, every ACC online. And it's like I had so much education, I was like overwhelmed. Met all of my requirements for sure. So thank you very much for inviting me and asking me to be the honorary president. It is an honor. I thank you, and I'm amazed at all the people online that are listening in. So thank you very much for coming. wanted to just start off with a bit of a historical story, which will unfortunately age me. And it just reminds me of like my life with, the electrodiagnostic realm. In my training, I was at Sunnybrook Hospital, and back in the day, they had a veterans wing, and there was a cardiac arrest that would happen, and you'd have to like trudge over to that wing. It was like quite far actually, and you get over there, you'd be huffing and puffing, and then back in the day, and some of you older people will remember this, they actually had the little, you had to actually squeeze the electrodes and put them on. And so you'd put them on, and you'd be like in the middle of a cardiac arrest trying to put these electrodes on, and like one electrode would fall off, and then another one would go, you had to put that one on, and another one would fall off, and you'd be like, eventually you'd have 2 or 3 people hold the electrodes on so that you could actually get a 12-lead ECG on somebody. It was craziness, right? And we just think about where we are now, and I did visit the booth back there. I would encourage you to do that for those that are here, and learn about all the amazing things that we're doing now with electrodiagnostics. I know that we had a medical, actually not even medical, high school student, grade 10 high school student who was trying to apply work with us at Total Cardiology. And he had gone online, found a database of ECGs, and did an AI analysis to show that he could find their ejection fraction with the ECGs. And these are the type of things that, we're able to do now compared to holding electrodes on with their fingers on. So we've gone quite a way in many, many years. So I'm actually been asked to talk about cardiac rehabilitation, less about the electrodiagnostic stuff, but I actually brought in 3 cases for us at the end just to kind of show how we use treadmill testing to kind of help us with our stress testing patients. But first, I'm going to just talk to you a bit about, if I can change the slides, maybe this is the way to do it. It did change there, but not here. And it's on a different timeline, so I apologize for that. So I'm just going to go back one just to show you I do have some disclosures. I do a lot of presentations for many people, so they're all on there just to kind of be open about it. I have no financial disclosures for today's presentation. And just sort of to give you a background in terms of cardiac rehabilitation, from the standpoint of what we do, we have to remember that despite the fact that we've had a lot of advancements, there's still a lot of recurrent events despite best therapies. So here's a Canadian study, it's out of Quebec, and where they took about 850 patients and they looked and saw what are the recurrent events over 10 years. And what they found was that there was 42% of patients had a recurrent event, and the 10-year mortality was 19%, despite reasonably good therapy. So it just remember the fact that if we don't do these things, the mortality, morbidity rates are even higher. So it's important to do whatever we can to keep these patients, happy, healthy, less likely to have an event, and surviving longer for sure. And that is what we do in cardiac rehabilitation. We have good evidence that suggests that we decrease mortality, morbidity, and improve psychological well-being. And that's really important for the patients. We always talk about mortality, morbidity, but actually the thing that really matters is that they feel well and go back to living life and actually forget that they had their cardiac event. And so we try our best to help them to do that. And this is the team that we have that's helped us kind of get the Terry Kavanaaugh Award. I physically received the award, but it's really a team event, right? It's the entire group that's helped us. I sort of have the high-level ideas, and these are the people that actually make it happen. And so, again, every year we talk about how good we do, and we actually talk about how there's no angioplasters in the room. We save more lives than the angioplasty doctors do in their world. And we're not sexy, they do the sexy work, but we actually save more lives, right? Because we make sure those patients stay on their medications, exercise, and eat well. And we know that makes a huge difference to long-term outcome. They see them once, they open up an artery that sometimes saves lives and sometimes doesn't save lives. But what we do after they've done their thing is continue to make sure that these people don't have recurrent events and don't need to see them again. And I have to say that, this is on the backs of some giants. We talked about, how many years has this organization, Csct, been in play? Many, many years. Well, CACPR was actually founded by some of the people who founded my rehab program. So I sit on the backs of these giants. Dr. Don Meldrum, he actually started the rehab program in Calgary. And sorry, my slides are going weird here. And that was at the Calgary General Hospital. That was before we had almost any data, but he believed in the importance of cardiac rehabilitation. And he actually told me this story this year. It started in one of the lounges in the hospital. So it was like where the chapel was. It was a chapel lounge, and that's where he started the rehab program, which I found really interesting. And then he helped form that organization, the CACR, now called the CACPR, and then Cardiac Wellness Institute of Calgary, now called Total Cardiology Rehabilitation, and we've held the contracted services for that since 1998. He's currently retired, traveling, golfing, and actually pretty healthy, considering how many years he's been at the business. And Dr. Jim Stone, again, another founder of our, both, not of CACPR, but he actually wrote the first guidelines for cardiac rehabilitation, and he co-founded our rehab program as well. And he decided that the most important thing was we have to do interventional cardiac rehabilitation. It's not just exercise and advice. It's like, make sure you do the things that actually improve the outcomes. Don't just tell the family doctor to adjust the lipids. You adjust the lipids because you're going to make sure that they actually get the treatments that they need. And that's made a huge difference. And we have the data that shows that it does make the difference. And Dr. Stone said, we should collect all our data and we should analyze all our data. He had a PhD. He wanted to make sure that we did this in a scientific way. He has not fully retired. We're not sure if he ever will, but he's close to retiring. But he actually does play in a band for those that want to go look him up. I think he's on Spotify, Doc James and the Flatliners. I've heard him play. It's pretty good, actually. Sorry, my slides are not changing fast, so I think we got it there. So total cardiology rehabilitation history really starts back in 1996. We started that for our rehab program. We actually only had 400 patients, and it was a 3 to 6 month wait. And we changed that. And I'll show the data that shows that this makes a difference is we went to a 2 to 4 week wait, and now we treat 1,800 patients. So we're able to see a lot more patients in a lot shorter period of time. And we started off with just treating acute coronary syndrome patients. What we found is that there's a lot of other patient subgroups that really benefit from cardiac rehabilitation. So that includes both the chronic coronary disease patients, post-bypass patients. And when I first started, very few bypass patients actually came to rehab. And then we started engaging the surgeons. And once they bought in, we suddenly had a lot of surgical patients. We have probably more surgical patients than many other groups. And we also found out that reduced EF patients benefit. Now there's clinical trials that show the benefit. Transplant, ventricular assist devices, now they're a lot different. Back in the day, these patients would walk in, they'd have a big tube coming out of their chest and be walking around with their device that helped them exercise, help their heart keep going while they're exercising. It was rather fascinating. Post-valve surgery, thoracic aortic surgery. We also do prehab, so patients who are going to go for surgery. We found that it helps patients who have POTS. And one of our cardiac electrophysiologists actually asked us to help them with his POTS patients who are quite disabled. These are postural orthostatic tachycardia syndrome patients. So these are young people. They're disabled in their ability to do things. And by treating them with exercise, we actually improve their functional capacity. Peripheral arterial disease patients. Atrial fib, we have data, and I'll show it to you, that when we treat them with exercise, we actually decrease their atrial fibrillation. Early surgical access. So this is after the surgery, the surgeons sort of say, see you later, I'll see you in a month or two. We said, no, we'll see you right away, and we'll see what kind of problems you're having and help you fix them, whether it's wound infections, pneumonias, blood clots, whatever it is. Like, we help these patients before they actually start their rehab exercise program. And then we've embedded a heart function continuity clinic to capture those patients early after discharge from the hospital so that we can actually prevent them from going back to the hospital with heart failure. So these are the kind of things that we've kind of innovated on, which is, I think, one of the reasons we feel that we got the award for by the CACPR for our rehabilitation program. And this is a team. We have obviously an extensive team, physicians, not just cardiologists, but internists and family doctors, nurse practitioners, registered nurses, certified exercise specialists, exercise stress test assistants, registered dietitians, psychologists, and administrative support staff. So you need a lot of people to provide excellent care for patients. And what do we do for our patients? Well, we've changed it a bit, and now what we do is we see these patients over a 6-week period of time for exercise. They have an initial appointment and an exercise stress test, and then we do a 6-week program-based exercise program. Some of it's home-based, some of it's on-site, and then we have virtual classes. Again, things that we learned from COVID that we could do. And then a 6-week follow-up in risk factor management. And we then can make adjustments to the medications to make sure that these patients will be well cared for and have more likely to be on the drug therapies that they need. And if you look at the surgical patients, this is the early surgical access. So we capture the patients early, have them seen by one of our internists who's quite interested in it, along with our nurse practitioner. And we've actually collected the data that says that we have really helped these patients a lot because there's been tons of wound infections and DVTs and other things that family doctors, would have had to deal with. We helped deal with them before they ended up in hospital with these problems. And then after a period of the healing, we can get started and we do the same 6-week exercise program and risk factor management. And so we want to get these patients on therapy, and we want to make sure that they stay on therapy. So we try to do as much as we can to motivate them to stay on their medications and explain to them what they need done. At the MD appointments, we're actively managing the risk factors, as I said. So if somebody's LDL's out of control, we're gonna increase their cholesterol-lowering medications if they need to be on certain medications for the diabetes. And now we have good evidence that GLP-1 receptor agonists and SGLT2 inhibitors both will decrease cardiac events in patients who have diabetes, and even those without diabetes. GLP-1 receptor agonists, things like Ozempic, which you've all heard about, actually decrease cardiac events in obese patients with, or moderately obese patients with cardiovascular disease. So getting these patients on drug therapies that we know reduce risk is super important. And family doctors don't feel comfortable doing it. So we really have to get these things done. Then we do the 6-week management review, and then we follow them again at 12-week, 1-year, and 2-year with a stress test and cardiovascular exam and medication and risk factor review. Really important, again, to reassess whether or not these patients need, reinforcement, because believe it or not, if you look at the data, about 50% of patients or more will stop their statins who have a heart event at a year or two. So it's really important to follow up on these patients to make sure they're actually taking their medications. The scariest ones are those that have stopped their ticagrelor after they've had their angioplasty, and it's been 6 weeks or 12 weeks, and they've stopped it, and you're like, you could have stent thrombosis. We got to get you back on that right away. And we've had a number of those patients because they just didn't understand the instructions they were getting. What is it that we're actually providing? We have the on-site supervised exercise. We now have it in 3 sites in the city, so that allows patients to exercise closer to their home, makes a big difference for them. We have the core education classes. Again, these patients have to sign up for them. Sometimes they don't. You can't force people to do things they don't want to do. And these classes really help these patients understand what is their risk and what is the benefits that they get from both the program and the medications that they take, and what sort of diet should they adhere to. And then that's the first 6 weeks. From 7 to 12 weeks, they can continue on with the education classes, but then they have some virtual group sessions along with home-based exercise. And again, something else we learned from the pandemic, when you let people do their own thing, they're more likely to be compliant once you teach them how to manage it themselves. So we actually went from a 12-week exercise program supervised to 6-week supervised and 6 weeks of home-based exercise where they actually do it on their own, but with some support. So kind of slowly, weaning them off of our support to allow them to kind of get to the place where they can actually, be confident that they can manage their own exercise. And that's critically important from the standpoint of these patients in terms of their confidence level in managing their care. Okay, slide has changed. Now, I mentioned our research. Our research is critically important from the standpoint of informing our practice. And we're a small program. We get no funding for research, $0. But we still have 18 published manuscripts, 7 trainees who who are ongoingly publishing our data. We now have some CIHR funding for a randomized controlled trial. None of that money actually comes to us at the rehab program, but helps to run the research, that one research project that was funded. And for those that don't know, CIHR is pretty hard to get, so it's actually pretty amazing that we got one research grant from that. And then we developed a heart care data set where we took our data, merged it with outcome data from Approach, which is an Alberta database developed by Albertans in Calgary that has heart outcome data in it. So we can actually see what is it that we do that makes a difference to the patients, both from the standpoint of recurrent cardiac events and also mortality. Do we do something that makes a difference? And that's important. And do we need to do something different? How do we make sure that we improve outcomes? So if we look at cardiac rehabilitation attendance and outcomes, I don't know if the graph is on there, but what we were able to find by using our data is that, we reduce mortality by 40%, so hazard ratio is 0.59. All-cause hospitalization by 0.7 hazard ratio was 0.77, so reduced events as well, and hospitalization was also reduced. Remembering that this is retrospective data, so it's not as accurate, but we used the best available way to kind of analyze it using propensity matching, which is a better way to look at the data to make sure that you're not making too many errors. The prospective data suggests that it's probably about 25% reduction in events, so we're kind of close, but clearly our program does make a difference in terms of reducing both cardiac events and hospitalization as well as mortality. In terms of what are the components that actually improve outcomes, right? Because we do a whole stack of different things. And you got to know what makes the difference, right? Like you're doing a billion things. Is it just everything, or are there certain things that do make the difference mostly? And we actually looked at this when we looked at what about the amount of exercise makes a difference to patients' morbidity and mortality. And we showed that for every 1 MET improvement, at 12 weeks, there was a 13% improvement in mortality. And we looked at this in other ways as well. And, exercise, both the baseline exercise and the improvement in exercise actually makes a huge difference in outcome. So exercise matters, so we got to work on that. The other thing we found when we looked back was patients' LDL levels and whether they're on a statin or not makes a big difference. And we just have not looked at the data again for some of the other medications I mentioned, like the SGLT2 inhibitors and GLP-1 receptor agonists, because we have to update our database. But clearly those are going to show a difference as well. We haven't had a chance to look at that from our database. Are we doing a better job of getting patients on these medications that have proven benefit in randomized controlled trials? And does cardiac rehab help atrial fibrillation? We all see atrial fibrillation in all the work that we do. In fact, I say if I have a clinic without atrial fibrillation, it's a surprise to me. Now, other people like cardiac electrophysiologists, like Dr. Kavanaaugh here, may have the entire day of atrial fibrillation, whereas I would just have general cardiology patients, but lots of atrial fibrillation. So we need to do whatever we can to decrease incident atrial fibrillation. And if we look at our program, you actually have less atrial fibrillation when you have patients in a rehabilitation program. And other data from other studies have shown that moderate amount of exercise actually decreases atrial fibrillation. So important to actually advise patients to exercise to decrease their atrial fibrillation burden when they have paroxysmal atrial fibrillation. And there's a number of clinical trials ongoing now to see if we can improve atrial fibrillation burden with exercise. From the standpoint of other subgroups, we've looked at a number of other subgroups. Patients with kidney disease, I mean, they often have really bad outcomes. Whether they have chronic kidney disease and heart disease, do we benefit these patients? And so we looked at that, and they are more likely not to attend our rehab program, but if they attend, they are more likely to have an improvement in outcomes. So this was done by one of our colleagues in Edmonton who looked at our database and analyzed it. She's a nephrologist and was able to show this improvement in outcomes. So, again, just because somebody has chronic kidney disease is not a reason not to refer them. Sometimes people who look sick actually benefit the most from cardiac rehabilitation. And this is the data I was going to show you about rapid access. when we bring patients in, does it make a difference bringing them in quicker, right? So for those that remember, there was a time when patients came to the hospital with a heart attack, they went straight to the emergency room and they spent an hour there while somebody made a diagnosis, and eventually they went up to the cath lab. We were the first in Canada to start what's called the STEMI program, where we got patients, the ECGs in the ambulance, figured out that were having a STEMI, and went straight to the cath lab. We published that data. We, Dr. Tripolsi, published that data in Circulation, and we were the first in Canada to do that. And that was a specific program. I was involved in that initial part to get those ECGs in the ambulances to make that big difference. This is the back end of that. How do we get those patients then back home? Because we know they only spend a small amount of time in the hospital. They spend most of their time at home. How do we get them home safely? And so the part of the back end of the STEMI program was having them come to rehab before they come home. We said, well, we got to see them quickly. And we should probably treadmill test them early too. And I was advised by one of the leaders in cardiac rehabilitation that that's probably not safe to stress test them early. We decided we were doing it anyway, and we actually wanted to make sure we analyzed their data and make sure we were safe. We did that. We were able to show it was safe, but not only that, we improved attendance in cardiac rehabilitation. Now, this is in a clinical trial. We went from 50% attendance to 100% in terms of referrals, and completion went up to 72% from 32%. So it's more than doubled. And when we look at our data now, we actually see that about 75% of patients who've had an acute cardiac event come and complete our program. So we're about the same. We're able to hold that. And when we present this data to other groups, they look at it and go, how is that possible? I don't believe that data. And when we publish our data, nobody believes that we can actually do this. But we've looked again and again, we're able to do this. So time matters. So you imagine yourself, you've had a cardiac event, and you get called a week or two after the event. You go, okay, well, that's part of my cardiac event. You take another scenario. You have a cardiac event, you go home, you're back to work, or whatever you do. 6 months later, you get a call from a program out of the blue. Hey, we want you to come to cardiac rehab. You're like, I don't think so. I'm back to living my life. I'm fine. Why would I bother to go back? That's the reason. If you don't actually get to attend to people timely, it makes a big difference to patient psychology. And we forget about the psychology part of it, but it really matters. And then when you get them there, then you know you decrease events. So time matters. Get it done quickly. Get them in there. You've captured them now. And then take care of them afterwards and make sure that they don't have their event by making sure they get all the right treatment. So this makes a difference, bringing them in quickly. And we were able to pioneer this despite the fact that was back in 2009. But despite the fact we were told we shouldn't do this. So don't be afraid to do things that people tell you shouldn't do, because it actually could make a huge difference to outcomes. And I think we're one of only about 2 or 3 programs that can do that now, but we're seeing more and more programs kind of adopt this. Now, what about prehab? What about before surgery? These are patients who have had their angiogram, the surgeon said they need surgery, but they're not going for surgery for maybe a month or 2. Is it safe to bring these people in? Do they do better? Are they more likely to attend? The answer is yes to all those things. So if you bring these patients in before they have their surgery, and we wouldn't do a symptom-limited treadmill test. We kind of less exertion, obviously. We want to make sure that they're safe. And then you get them into some light exercise, some little bit of resistance training. And before you know it, these patients are in much better shape for their surgery. They have a better respiratory fitness. They have an improved body mass index, less anxiety and stress, and they're more likely to attend rehabilitation afterwards. This is not the hard outcomes. I think that's going to come. We're going to have more data that shows that it makes a difference in hard outcomes, but it certainly helps the patients feel more comfortable. They feel safe. They're in a place where if they start to run into trouble, we can actually help them quickly, right? That's the point. We want to make sure we can help these patients when they run into trouble. And we've had several where we've actually had to send them to the hospital quicker and say, hey, can you get their surgery done? They're having increasing angina. Makes a difference. And this is something we don't talk about much, although we're starting to see more of this. And one of our psychologists has developed a program for healthcare practitioners for motivational interviewing. And so this is really important. Motivational interviewing is really about how you talk to the patient to make sure that they are self-empowered, that they have their own goals, and that they make sure that they are managing their own health, right? So if they can manage their own health, they're going to do a much better job. And so we looked at, does a motivational interview help patients more likely to come to cardiac rehabilitation? And we're able to show that by giving them motivational interviewing, talking to them in a certain way that actually makes it more likely for them to come to cardiac rehabilitation. And the same techniques can be used to help patients stay on their exercise, eat well, and take the medications. So again, I think these are all important. Now I'm going to talk about the pandemic. I know nobody wants to remember it, but it did exist. It did teach us a lot of things, right? And you guys this will all resonate with everybody here, right? We learned how to adapt on the fly. I never saw processes change so rapidly as during the pandemic, right? Like we said, we got to do this. Well, you didn't have 10 committees that you had to discuss it with. It's like, okay, we're doing it, and off you went, right? We went from paper records at the hospital to electronic records during the pandemic. And so, that made a huge difference in terms of, how we managed patient care because we went to electronic records. We were able to do virtual classes. We actually had virtual billing codes, which made a difference. We had all kinds of things that really just sort of helped us manage these patients better. And all of our programs' processes changed over time as we did that. So that made a difference. And so you saw that we went from a 12-week to 6-week, home exercise, virtual classes, many more phone calls, made a huge difference. My slides have disappeared here. I have no idea what it's doing. I apologize, but I cannot see my slides. Okay, I will not use that anymore. I'll just look over here once in a while. In terms of cost effectiveness, because we were able to look at our data, we decided we needed to do a cost effectiveness analysis. So we worked with the University of Calgary, and we found a researcher that was willing to kind of look at our data and do independent of us cost-effective analysis, and was able to show that we were well within the cost effectiveness that is considered to be a reasonable amount for something you should pay for, right? So cost effectiveness, $50,000 to $100,000 is a reasonable amount per year life saved, and we're well below that. We found that those that have an ACS and those that are older seem to benefit more than those that are younger, on those that have not had an ACS, but clearly there was improvement in terms of cost effectiveness. And this does matter because you got to know what to pay for, right? You don't want to pay for everything, so you got to know what to pay for. Now, the next question you might have for yourself is, well, why do you do a stress test? Not every program does a stress test, cardiac rehab program. And so I'd like to sort of just talk briefly about that. I will say that, we bring patients 2 weeks after they've had their cardiac event. And so we're bringing them in very fresh. You want to make sure that they're actually safe. So it helps us with our heart rate targets. We make sure that they don't have an ischemic change, they're not having arrhythmias, that they feel comfortable with exercise. So these are some of the things. Psychologically, it helps. Do they have a blood pressure problem? Do they have blood hypertension? Like, for example, somebody who's got a fresh, aortic surgery, or we wouldn't bring them on a treadmill in 2 weeks, but like after their healing period, we're going to put them on a treadmill. You're going to make sure they don't have a hypertensive response because maybe the rest of their aorta is not completely normal. So, those kind of patients may benefit from that, or a fresh mitral valve repair. We don't want to really drive up their pressures really high early on and cause that repair to fall apart. But yet those patients still want to exercise. Oftentimes they're younger, they want to exercise, they want to feel good. How do we do that safely? So by just doing a stress test, looking at their ECG, seeing what their blood pressure is like, we actually get a good idea of what's happening in these patients so we can give them a good exercise prescription. So I thought I'd just make this a little bit fun at the end with just a couple of cases. So I've got 3 cases. The first one is a 74-year-old, and I apologize if I'm looking sideways just so I can read it. Previous bypass with multivessel coronary disease, has gout, EF of 50 to 55%. He was on metformin, clopidogrel, rosuvastatin, ezetimibe, metoprolol, and telmisartan, and we did a stress test on him, I think it was like 4 to 6 weeks after his cardiac event. And this is his angiogram. You can see this is our carrot diagram that we developed here in Calgary, and it shows all the black stuff is bad, more black is worse. So you see a lot of black stuff there. There's a lot of disease. So this person ended up needing a bypass for his coronary artery disease. And I cannot see this, but I'll just say that, this patient did go on the treadmill test. You can see on the top right their MET levels. So went on the treadmill test. We wanted to see what they did. You can see here the ECG shows sinus rhythm. Not a whole lot. This is the baseline ECG. And you can see this person is exercising further. Sorry, this is not working. Please go to the next slide. That's not going to the next slide. Yeah, in recovery, sorry. So this is a normal patient who exercised, did okay, but when they're on a beta blocker, what can happen is sometimes their heart rates don't go as high. Now this person, their heart rates went not too bad, okay? So now you say, well, how would you give a prescription? Let's say they're on like even a higher dose of a beta blocker. Would you use the regular like 220 minus age and then multiply that by a percentage? You won't get the right heart rate target for that patient. So if somebody's on a beta blocker, we want to know what is their heart rate at peak exercise when they're maxed out minus their exercise at baseline. That makes a difference, right? And so that's going to be a different heart rate target than if you just use their age predicted heart rate, right? Ooh, sorry, now it's gone 2. Can you go back one? Back one more? Again? There, and one more. It went forward 4 slides. Okay, so this would be, for example, this patient's calculation for what their exercise should be. Up at the top is their actual prescription that the exercise specialist put together for them, and they do that right at the treadmill test. So they get their treadmill test, and we immediately give them their exercise prescription. So in this particular case, they took their peak heart rate minus their resting heart rate, and then they multiply that by 60 to 80% as being the range that you want to add to their baseline heart rate. So that's how they calculated this person's exercise prescription. And this, I say, about 105 to 116 beats per minute. And so that's what their exercise prescription would be. Whereas if you use, 220 minus age times a percentage, in this particular case, it turned out to be not too bad. But there's other patients who are massively off, where if you actually told them that they would go by their age predicted, you'd end up giving them too high of a heart rate and they'd never achieve it because they're on their beta blocker. So have to be a little bit careful about that. And then can you go to the next slide? So the next patient, patient LM, 70-year-old with atrial fibrillation, mild LV dysfunction, mild inferior ischemia on the MPI for medical management, has a pacemaker in as well, and is on valsartan, rosuvastatin, flecainide, diltiazem, dabigatran, levothyroxine, tamsulosin, and colchicine. You might ask, why is this person on flecainide? They were on it before they had their bypass before they had their ischemia identified, but were never taken off of it after that. They had their stress test performed. And again, I can't fully read this, but they had their stress test. And you go to the next slide. So this is their baseline ECGs, a few extra beats there, a few PACs. Next slide. Going a little faster there. And next slide. And then there's this wide complex beats. What were those wide complex beats, right? So the physician who analyzed this thought, well, it might be VT, it's wide complex. I kind of looked at it, maybe there's a little pacer spike in front of each of those. The rate is around 150. What is this? Is this VT? I mean, we can't necessarily tell based on just the 12 lead ECG in this particular case. Go to the next slide. But, we had the device settings and we had the pacemaker report that came a little bit later. Again, if the heart rate went to 150, this patient's heart rate's max is on the pacer is only supposed to go to 130. So, maybe it is VT. If you look at the next slide, you'll see that this person both had atrial flutter, lots of atrial flutter, and also had short runs of non-sustained ventricular tachycardia. So had both happening. And so wasn't really sure. What did we do with this patient? Oh, sorry, the next slide did not happen. That's their pacemaker report, showing that they had both atrial flutter and non-sustained VT. So it was useful that we didn't just say, hey, go and exercise. We did a treadmill. We figured out what was going on, made some adjustment to meds, and then we repeated the treadmill test. You can go to the next slide. So this is the switch that we made, or that was made. I wasn't involved necessarily in this patient. And then, next slide. Then we repeated the treadmill test. And what you can see is a few short runs of atrial fibrillation, but no wide complex beats. So that was a success. That was helpful to do the treadmill test on that patient. Here's another patient, 67-year-old with angina, did not have an MI, had an MPI that showed severe ischemia, and an angiogram that showed 50% RCA with marked reactivity. And they're on aspirin, rosuvastatin, ezetimibe, irbesartan, and amlodipine. And probably the amlodipine because of the reactivity, so it just means that the arteries kind of, when they put the catheter in and injected it, or when they put the catheter, just engaged the catheter, the artery kind of, squeezed down, they became much smaller. And this is the angiogram. Really didn't show a lot of disease. There was a 50% sort of mid-distal right coronary artery lesion, but the rest of the arteries looked not too bad, but they comment on the reactivity on the angiogram itself. And again, they underwent a stress test at our institute. The start of the ECG looks pretty reasonable. They're going along. You see a little bit of SC segment depression happening laterally. A little bit more SC segment depression laterally. And, I don't know what happened there. Went too fast. I am not controlling that. It's just doing its own thing. And you see here, this is sort of near the end, there's actually SC segment elevation inferiorly, right? So there's clearly significant spasm happening in that right coronary artery. So this patient had a nitro patch that was added. You can't go in there, you're not going to probably go in there and plasty that 50% lesion. You're going to say, that lesion you're going to need to give more, drugs that are going to decrease the reactivity. They were already on amlodipine, so we added a nitro patch, and then they had a repeat treadmill test. And there's still some degree of SC segment depression, but it's nowhere near as much as before, and no SC segment elevation, no symptoms. So much happier. A happier heart. So in summary, cardiac rehabilitation is, really key to helping these patients going back to living life, making sure that they don't have cardiac events, make sure that they, less likely to die from these events, improve their well-being, self-confidence in terms of taking care of their health, and understand why they need to be doing what they need to do to try to prevent these events, right? This is what our goal is. And I'd like to, again, emphasize, this is team-based care. Every team member matters on the team. I'm just one member. I'm the physician, but, everybody matters. And it's oftentimes the exercise physiologist who are coming to me and says, actually, did you notice this on the ECG? And I'm like, yeah, no, you're right. So I'll change my report and, maybe have a different conversation with the patient. So it's really important to have everybody's eyes, because the more eyes you have on it, the less likely you are to make mistakes. So don't be afraid. Your physician should not get upset at you, but sometimes they do. I understand that. That's not right. But this is about patient care, and we all work together. It's a team. And so I'd like to thank my exercise specialists, certified exercise specialists, for helping me make sure I take care of these patients well. And I thank you all for listening and open to questions. Does anybody have any questions in the audience? I can't check online since, yes. And I don't know, is there mics, or I can just repeat the question?
It's coming.
Oh, it's coming. A mic is coming.
Yeah. Please step up, form a line here to the mic if you have a question.
Hello. Could you just clarify what you meant when you said decreased burden of AFib with exercise? Is it frequency of events or rates?
Yeah, so yes, frequency of atrial fibrillation events. So less likely to have those. Now, in this particular case, when we look at it retrospectively at rehab, we're looking at symptomatic AFib events, right? Because we're not continuously monitoring. There's going to be other studies that are going to look at that and maybe give us some better information about whether or not there's asymptomatic AFib events that are also decreased. And certainly there's other clinical trials that are looking at that. We actually have a research study that's looking at whether or not helping patients with weight loss can make a difference to AFib events, right? So, that's just behavioral management, not drug therapies. There are drug therapy trials that are going to be looking at things like using, Ozempic to try to decrease, patients' weight. Maybe the fat around the pericardium matters, and that increases atrial fibrillation burden. It's hard to know for sure. So we're looking at that as our research trial to see whether or not we can improve atrial fibrillation burden for those patients as well. Other questions?
Hello. Just wondering the cost to patients for your cardiac rehab program, and if you're able to speak for a second on the ECG and EF, the AI that you were speaking at the beginning.
Oh yeah, sure. So for our program, most of the cost of the program is covered by our contract. There's a smaller administrative fee. It's been changing, so I can't remember exactly what it is right now. It's around $350. But only about 50% of patients pay that. Like, we actually have a waiver for anybody who cannot pay for it. So maybe 50% of the patients pay for it. The other 50% do not pay if they can't afford it. And it's not like 10-page form. It's like they come up and they say they can't afford it, and that's the end of the cost question. So nobody's really supposed to not be able to attend for cost reasons. So that is not a reason not to attend. The second question in terms of the ECG, like, there's a number of different things. Like, I know that one of my colleagues, Dr. Exner, worked on with a bunch of engineers out in Toronto to see whether or not they can use ECG, Holter, and other things like that to actually predict ejection fraction. How it does it, I cannot explain that. It's much more complicated in terms of my ability to understand what's being done. The person I'm talking about was like a student, and that person actually just used an online database and was able to figure this stuff out using artificial intelligence. But I can't tell you how he does it. There's a lot of different algorithms. We have a colleague, Dr. Miller, who actually has done some amazing work with artificial intelligence and its ability to look at nuclear cardiology studies, and actually presented and received an award for the work that he's done. So there's a lot of stuff that's happening. I know there's a program out there, or a number of programs right now, with artificial intelligence and echocardiography, and we looked at one specifically to see about maybe implementing in our echo lab, where it'll actually analyze the echocardiogram, do all your measurements, and spit out the measurements for you. So then the technologist would not have to do any of the measurements. They just have to do the scan and do the other part of the interpretation part of it. So, we're seeing this come along in multiple different ways, some of it better than others. And what we have to understand is, these are tools to help us work more efficiently. It's not supposed to take away jobs, but rather make it so that we can do things quicker, more efficiently, rather than, and take away the burdensome part of our work and make it so that we can focus more on the clinical aspects of the care, or have a conversation with patients, right? So I'm starting to use an artificial intelligence, Heidi, which allows me to walk into the room, have a conversation with the patient, and when I walk out, my letter is done. I don't actually have to do any dictation. I have to read the note, make sure it's correct, 99% correct, very little bit of changes that I need to make, and I come out and my note's done. And it's even better for those people who have to spend half an hour, 45 minutes, or an hour with a patient. You walk out, all of your note is done, your entire conversation is done. If they speak a different language, it translates it and puts it into your note. So it's actually a better note than you could have done yourself. It's incredible technology that's coming, that's going to really help us take away the burdensome part of our work, which is, the documentation, the manual measurements, the putting data into different places. So I think we'll see more and more of that. This was not supposed to be an AI talk. I think, yeah.
Yeah, okay, allowed to ask?
Yeah, we have time for
Well,
more
it's a great
questions.
presentation, Dr. Sandeep, and it's very informative. Just curious to ask few questions. On the case second, when the patient was having AFib during his treadmill, do those tests are the only one, or you are planning to do something more after that to 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 just to clarify, because that's the only one stress test, right? We just got it. So what's
Are you talking about the management of that person's
yeah,
atrial
the
fibrillation?
future strategies?
So we at Rehab don't claim to say that we're going to start managing patients' atrial fibrillation. It's important for us to, give that information back to their primary cardiologist, their family doctor, other care providers to help decide on management of atrial fibrillation.
Okay.
As you know, atrial fibrillation management has changed over the last 10 or 15 years. It's gone from a rate, control, anticoagulate to, we need to do more rhythm control. And so it's changed from one to the other. I don't know if you can hear about that today or not. So we provide the information. If appropriate, some of those patients will be referred on for further, treatments, whether that's drug therapy or whether that's, he's on drug therapy now, but maybe needs to be on amiodarone, maybe needs an ablation. All those things need to be considered, again, not by us. And I can't say for this particular case if he will or will not. There's a lot of factors that go into making that decision, including, the current wait time for atrial fibrillation ablation. In Calgary, about 2 years, right? So it's a super long time for patients. So I have those conversations with patients, and I also have the conversation that, if you want to pay for it privately, you can leave the country and get it done, which is kind of a shame that we have to do that. And we really, knowing the burden of atrial fibrillation and what it does for patients' quality of life, like ideally that wait time should shorten, because it really does make a significant difference to some people in particular for their quality of life. But the reason that we're doing a lot more AFib ablation is there's now more and more data that harder outcomes are benefited, not just their symptoms, but less likely to have, hard outcomes, dying, having other, events happen to them, stroke, etc. So like we've got to think about that, and that's why we're doing more and more AFib ablation. And it was really easy for us before when we could just say, rate control and anticoagulant. Now we've got to, find places to do cardioversions and then try to keep them in a normal rhythm, refer them on for ablation. And I think our job's hard. The EP docs have to talk to them and say, yeah, thank you very much, but it's now a 2-year wait for your ablation. So again, I think it's important. Not within our realm from the standpoint of rehab, when I have my rehab hat on, but in my office for sure, I would be dealing with that on a regular basis.
All right, and one more question, that the patient who's having low EF, like how do you go about those patients, like for the rehab, like pre any surgical management?
Yeah, so patients who have low ejection fraction, again, I think people have historically been afraid of sending those patients to rehab, but actually there's good data that suggests that these patients actually do better with cardiac rehab, whether it's whatever heart failure type, heart failure reduced EF, heart failure preserved EF, there's data that suggests that these patients benefit. There was a study called Heart Failure Action that showed that these patients are less likely to have heart failure admission events when you exercise these patients versus not. So again, it's endorsed in the US and in Canada as a primary indication for those patients. From the standpoint of practically what we do, we want to make sure obviously they're not congested when they come in for their rehab and they do their stress test. And if they're not congested, then it's safe to do a low-level exercise test, get an idea of their functional capacity, and then along with all of the other things that we need to do in terms of medications, great medications that are available that we're not necessarily adjusting on them. If they're managed by a heart failure clinic outside of our clinic, then we'll just exercise them, get them to be more functional, and it's amazing between the medications and the exercise how much better they feel at the end of their exercise program.
The first will be the medical Okay, we'll discuss. Thank you.
Thank you very much.
Just a second, Dr. Argawa. Thank you so much for being our honorary president this year and your talk. We are very grateful.
Thank you.
Okay, we just wanted to make an announcement that there was a little bit of a technical glitch online, unfortunately, and people weren't able to see the video feed. Don't worry, you will still get your CEUs if you were online. That is not your fault. So you will still get your CEUs, don't worry, for all the online people. So if you are online, you don't have to worry in person. If you're online, you need to get out of this presentation and go into the next one and ensure that you put in your code access for the next presentation, please. The code is CSCT. Just a reminder for anyone who's still online, you have to be checked in online to get your certificate. You won't get it if you are not checked in online. All right, our next speaker will be Dr. Kavanaaugh. She is an associate professor in the Department of Cardiac Sciences and Medicine at the Cummins School of Medicine, and is a distinguished cardiac electrophysiologist and cardiologist at the University of Calgary. A pioneer in the field, she was the first ever cardiac electrophysiology fellow at the University of Calgary. After completing her medical degree at Memorial University and cardiology training at Dalhousie, her career initially included a focus on wet lab research with funding from major Canadian foundations. However, her passion evolved into a dedication to residency and fellowship training. Dr. Kavanagh served as the EP Fellowship Director from 2004 to 11, and later the Cardiology Training Director from 2011 to 2024, where she was an influential educator. She remains a tireless advocate for clinical research, actively promoting and optimizing patient enrollment in numerous seminal Canadian trials, including the AF, CHF, BRUISE, and REFINE studies. Please help me to welcome Dr. Kavanagh and enjoy the presentation on the topic, Is There More to a Holter Than Arrhythmias?
Hi, everybody. It's nice to be with you today. Nice to see so many people out early on a Saturday morning, so very, very nice to meet you. And I'd like to continue the theme of Dr. Thierry Kavanagh. I've never met him in face-to-face, but we've had lots of correspondence, because when I started my EP career, I was getting all these emails that were supposed to be for Dr. Thierry Kavanagh. Now, Catherine and Thierry seem very different, and K and T, but I get his emails. Then I start getting the letters, the actual slow mail. But when I started getting his bills, that was another matter. How that happened, I don't know. Canada Post and email really mixed it up. Now, if he was getting my bills and taking care of it, maybe I wouldn't complain, but I never heard about that correspondence. But that's my relationship with Dr. Thierry Kavanagh. Now, I'm going to try something, because I like to wander when I talk, and I like to point. Okay, so let's see if this works. I'm supposed to stay on the dance floor, they said. And if I stay on the dance floor, this should work. So I'd like to start off reminding us all that we are in southern Alberta, that we are on the traditional territories of some of our Indigenous people, okay, the peoples of Treaty 7, which includes the Blackfoot Confederation, the Tsuut'ina Nation, and the Stoney Nakoda. The city of Calgary is also the home of the Métis Nation of Alberta. So I'd like us to recognize that. Now, this is supposed to go forward. Okay, so my topic today, can you see me? Am I staying in range? Okay. Okay, I'll stay on the dance floor. Is there more to Holters than arrhythmias? What do you think? Okay. I'm sure that you've all had lots of requests for tachyarrhythmias, bradyarrhythmias, palpitations, causes of syncope, and the effectiveness of the whatever medication we put them on. Okay? Those are your typical requests, right? Now, who's had a request for a Holter request for T-wave alternance and heart rate turbulence? Can I see a show of hands? How many have had a request for that on a Holter? I see one, and they're from one of our vendors down there. And we have someone here that's had a request for that. So it's not a common request. Now, I know that you've had a session on this last year, I think, for T-wave alternance, and I see that people down there may have been involved with that because there was a lot of software done, and I think you had a session on how we do that, okay? And I think you can be thankful with the equipment that we have at the moment, okay, especially the recording equipment and the analyzing equipment, that you don't get requests for this, because most of you would be bald because you've pulled out your hair, okay? Except some of us maybe, okay? But we need clean recordings, okay? Very clean recordings to be able to do this, okay? And sometimes I'll show you some of the what I'm talking about here, but we need better recordings, and they're working on that, and for acquisition, and you need more efficient, I guess is the best way to say it, to be able to analyze this in a reasonable amount of time. I know that some of our technologists were involved with doing that with Refine ECDE, and I should say Refine ICD. I got it out. It's too early Saturday morning. Okay, and it wasn't the easiest thing to do, okay? So what are we talking about? Talking about making this thing work. It's not showing up. Oh, okay. I didn't know it was going to do this. Oh. Okay, that's a bit of a surprise. On my computer, it looks like this. So when we look at the T-wave alternance, okay, we're looking at repolarization. Most of the time when you're asked to look at Holters, you're looking at the QRS, you're looking at the P waves, okay? You're not looking at repolarization or the T wave, except if you're looking at the ST segment and if there's elevation that might suggest ischemia, okay? Or changes in the ST segment. But if you look here at the complex that's been magnified, I think you can see that there's definitely a difference. Yeah, this point, you got a better pointer? Oh, okay, I got to stay on the dance floor.
If you push in the middle, maybe it doesn't go very far. Do you see it? A little bit there.
No, I don't see it. Okay, so look in the circle.
You need to point it that way, and if it doesn't work, just say next slide, and I'll advance the slide for you.
No, I don't want to advance the slide. I want the pointer.
Oh, it's just the circle.
It's not working.
It might not.
Oh, okay, okay. So look in the circle there. Look at the T wave, okay? I finally got it to do that. And you can see that there's a difference in those two T waves, okay? And what it's doing, and if you look at the first two QRS complexes, I think that you can see that the T wave is wider and flatter than the next one. So it's looking at the differences in the T waves, okay? Now, sometimes you can see it in macro, but sometimes it's very, very small, okay? And you probably would need artificial intelligence to get through a Holter monitor looking at all of those T waves, okay? So that's the T wave alternance. Now, let's see if we can move this. Okay, so the other request, turbulence. Anybody had a request for turbulence on their Holter monitor request? No. Okay, so if you look at the first complex, what we're looking at is what happens after a PVC, okay? And I've labeled the normal one, and if you look at the red line after the QRS, what happens is that the rate after the PVCs is faster, okay? If you look at the RR intervals after the PVC, they're initially faster, and then they slow down, okay? So we look at the onset of the fast rhythm after, or the fast QRSs, and then we look at the slope of the other part of that red line as they slow down. Now, if you look at the other aspect of that, this pointer, you can see I've labeled it abnormal, and you can see that there is definitely no change in the rate of the QRSs after that PVC. Okay, so that's abnormal. So why do we care about this? Okay, can you advance for me? The next one? Oh, sorry, go back. Okay, so why do we care about this? There should be, can you just, no. Okay, so both of those those of T-wave alternance and turbulence, okay, have been found to be markers of risk of sudden cardiac death or cardiovascular mortality, okay? So that's why we were hoping that it would be relatively easy to look at those things on a Holter, but they're not so easy. But are they really important? So that's what we want to talk about, okay? There's been lots of studies to show that they are markers. Can you move to the next slide, please? Okay, so now we're going to look at the development of a cardiac arrest. What does it mean to a patient? What's happening for them to have a cardiac arrest? What are the elements that are involved? And we're talking about patients that have had a heart attack, okay? So we know that the underlying substrate is not normal. They have a scar, okay? And we often refer to that measurement as looking at their ejection fraction, how much damage they've had to their heart, okay? The autonomic nervous system plays a role, okay? And that's the turbulence aspect of things, okay? And then there's the dynamic substrate, and that's repolarization. What's going on in various areas of the heart when it's repolarizing? And that's where we see changes in repolarization in various parts of the heart and the T-wave alternance. So that's what goes into the development of a cardiac arrest post-infarct. Need to advance, please. I think you may have gone too far. Just one. Okay. So, way back, 2007, going way back, Dr. Exner in Calgary, and I was in Edmonton at the time, and we did a study, actually it was across Alberta. It was called the REFINE study. And basically what we did, we looked at patients post-infarct, so they had their scar, and we looked at heart rate and T-wave alternance, okay, in patients that had heart attacks, and we looked at what happened if their ejection fraction was greater than 50% or under 50%. And we found out that the risk of a cardiac arrest was higher in those patients, okay, significantly higher as you look at that red line or brown line, however it looks, it's supposed to be red. And they had a scar, heart rate turbulence, and ejection fraction of less than 50%, okay? So we knew they were at risk. But this was a cohort study, and it was only in Alberta, and we weren't really doing anything for the patients as to not prevent them from having increased death or cardiac arrest. Okay, now post-infarct in patients at the present time, the guidelines indicate that we recommend a primary prevention. That means after their heart attack, they haven't had a sudden cardiac arrest, okay, but their ejection fraction is less than 35%, and they're on optimal medical therapy. And you may have heard that referred to as GDMT, okay? They're on the beta blockers, they're on the spironolactone, they're on all of the good medications that have come out recently, okay? Go back, okay? We did not look for we don't look for other markers in those patients. If their ejection fraction is 35%, then it's recommended that we put in a primary prevention ICD. Okay, now we can move on. But let's look at the disease burden, because if you remember in REFINE, we looked at patients who had less than 50% as well as the markers, okay? The guideline looks at patients with an ejection fraction of 35%. So there's a whole lot of other patients in there, okay? So if we look at what's the burden of an MI or sudden cardiac death, okay? And this is American data, but you can see the numbers are very, very high. 1 million people will have a myocardial infarction, okay? A lot of them will have a recurrent, and some greater than 500,000 will suffer from sudden cardiac death, okay? And this was dated in 2015. However, there was a report from the American Heart just recently, 2025, and they said there's no real significant changes in those numbers, okay? So what does that translate to? Okay, stop there. Okay, so now, just to look at this chart, if we look at everybody, all adults, okay? Now that's a big denominator, okay? The total number of cardiac deaths will be very, very high, just because of the big number of patients, okay? That's all cardiac deaths, okay? The coronary artery subgroup, again, in the general population, okay, there will be a large number with coronary artery disease, and quite a number of them will have an MI. Now I'm going to drop down to the ones with the ejection fraction of less than 35%, okay? You can see that a large number of them will have an event, okay? Will have a cardiac arrest or mortality, okay? And that's why we offer them, you can see the orange, you can see the blue is the denominator, the orange is the number that will have the cardiac event or total number of events, okay? So the number there is high, and that's why we put in the ICD, primary prevention ICD. Now, in between there is the group that have the MI, and the ejection fraction is greater than 35%, but it's not normal. And for the purpose of our REFINE ICD study, we defined anybody less than 50% and greater than 35%. That's the group we looked at for REFINE ICD. One slide, please. Okay. I'm sure most of you in this room have heard of REFINE ICD. I'd be surprised if some of you had not, because it went on for a long, long time, okay? Long time. And basically, we were looking at risk estimation following an infarct. It was non-invasive evaluation and ICD efficacy. Next slide. And we had a lot of support, as you can see there, okay? We had support from Libin, we had support from Medtronic, we had support from a number of the granting agencies, from GE, which we're very, very thankful for. Now, it was a study that was more than nationwide, it was worldwide. The next slide, I think, will show you that in larger. So, our Canadian centers, we had some 25 Canadian sites. We had some 26 US sites, at least initially. And we had sites in Europe and also in Australia and South America, okay? And also Saudi Arabia. Okay, next slide. These are our Canadian sites, so that's why I'm sure most of you have heard of Refine ICD, okay? Next slide. Okay, now there had been other studies that showed that putting an ICD in early after an infarct did not benefit patients, okay? So that was one of the things that we had to look at here, because those studies had already been done. So what were we doing with Refine ICD that was different? Next slide, please. Okay, so we looked at patients later after their MI, okay? We studied both the unstudied population, like we said, ejection fraction less than 35, greater than 35%, but less than 50%, okay? Then we incorporated T-wave alternans and turbulence. You remember I told you they were markers, and we know they're markers, but we never used them to guide therapy. So in this study, we were using them to guide therapy, to see if there was anything we could do for those patients that we knew were at risk. Besides knowing they were at risk, could we do anything to reduce that risk or treat them if they had their event? Next slide. Okay. Now, things changed. I told you this went on for a long time. 2011 to 2025 was a long time doing this study. A lot of things changed, and I know you can't read that, but the medication changed. Way back when we started, we were talking about beta blockers, okay? Now we have spironolactone, we have Entresto, we have the DAPA, the EMPA, all of those, the Ozempic. We have all of those medications that came online and are being used since this study started, okay? So there have been some changes, and as you heard from my colleague down there, Sandeep, that they have made changes and they're looking at the data as to what that has done to mortality and cardiac arrests. Okay. Now, in this trial, our hypothesis looked at patients with a scar, okay, we talked about the ejection fraction, patients who had both, okay, the T-wave alternans and the turbulence, okay? They had to have both. And then they were randomized to the usual treatment, okay? And medication was added over the years. And also medical treatment, optimized medical treatment, and in the other arm, adding an ICD, okay? So the difference between the two groups is that one group got an ICD, and it was after 2 months, post-MI 2 months, at least 2 months, okay? 2 months to 15 months, and if they had surgery, then we didn't assess them until at least 3 months post-surgery, okay? And we looked at all-cause mortality on the basis to intention to treat, because there were some crossovers, okay? Mortality was adjudicated, modes of death, also by intention to treat. Gotta go back. Okay, so if we looked at the flow, so ejection fraction 36% to 50%, okay? 2 to 15 months post-MI, 3 months post-revascularization, if they had revascularization, less than 80 years of age, and they were not accepted into the study if they're on dialysis, permanent atrial fib, okay? Antiarrhythmic drugs, okay? Also, if they already had a device in place or a pacemaker in place, they were not accepted into the trial, okay? You might say, why atrial fib, since we talked about atrial fib? If you think it's hard to look at the T wave with sinus rhythm, try looking at it with atrial fib, okay? So that's why the atrial fib patients weren't in, okay? Primary outcome, mortality, okay? And then there's also going to be a part of the study, cost and quality of life. The mean follow-up was 5 years, okay? And then, as I said, we did a Holter. If they had abnormal T-wave alternans and heart rate turbulence, they either got usual care or usual care plus the ICD. Those were the two groups in the randomized arm. Now, if they didn't have T-wave alternans, or they only had one or the other, heart rate turbulence or T-wave alternans, then they went into the register. They weren't in the randomized group unless they had both, okay? Next slide. I want to get the full slide here. It's coming up in pieces. Okay, thank you. Okay, so we screened quite a number of patients, as you can see, 1,900, 1,950 almost, okay? And we randomized 597, okay? And Calgary was the top enroller in that study. We enrolled 20% of the patients that were randomized in that study, okay? Now, why were they excluded? We talked about some of that before. So we screened them, but they were excluded for various reasons, okay? Or not eligible if a normal heart rate turbulence or T-wave alternans, or they went into the registry, okay? Randomized patients, to move down to the randomized patients, there were 291 in usual care, and 306 received an ICD, okay? Now, some people did not receive an ICD, small number, and there may have been changes in their condition, or they decided not, they didn't want to have an ICD, okay? Others had to cross over because they may have had a cardiac arrest, and we had to put in an ICD. So there was reasons for crossover, but there weren't very many that crossed over. Okay, so the two groups were fairly equal. We looked at age, BMI, ejection fraction, and hypertension, and you can see that both groups were very well matched except for one, which is very common in cardiac trials. And you can see that red star, okay? The number of females in this study was very, very low, okay? And that's something that we're continuing to look at. Why? As I told you, we randomized a lot of the patients, and we did not discriminate between men and women. And the only woman that refused to go in, for me, she was moving back to the Philippines. So that wasn't possible. But that's the only woman that said no. And there were a number of gentlemen that said no, and they had good reasons. Why did they say no? Truck drivers, okay, we're talking about a primary prevention ICD. If they had an ICD, then trucking south of the border was a problem, okay? So they would say no for that. The other thing is, if you're the type of equipment that you might be working with, the large magnets, things like that, they also said no if it was going to interfere with their work. So a number of the gentlemen said no, okay? So this is usually an older population. When we hear excuses as to why women aren't included, we hear, well, you know, it's hard for them to get to their meetings and, you know, visits and things like that. They're looking after children, they're looking after their husband. But these were older individuals, and childcare did not come into play. I never heard any of those reasons for not participating. So we're trying to look a little bit deeper into this particular group as to why we didn't have more women in this trial. And then we looked at some of the medications that they were on, and again, it was fairly balanced between the two groups. Next slide. Okay, for the results. If you look at, now this is looking at the two randomized groups, okay? Or the groups randomized and the groups in the registry, okay, for this slide. This is the randomized and the registry. And we see that the rate of risk of death was much higher in the randomized group rather than in the registry, okay? So again, that says if you have the T-wave turbulence and the T-wave alternans, if you have both of those risk factors and the ejection fraction, then your rate of mortality is much higher, okay? Now the next question is, were we able to do anything about it? So this is, oh, go back. Yeah, that one. They're keeping you all in suspense. That's all it's about. We paid them. Yeah, we're keeping them all in suspense. Okay, thank you. So now we're looking at that graph shows what happened with the patients that received the ICD with the red line and the blue line. Those patients got no ICD, okay? They had the ejection fraction reduced, they had T-wave alternans positive, and they had turbulence positive. The only difference was the ICD. The ICD did not prevent all-cause mortality, okay? There was no difference between the two groups. So giving them an ICD did not help. Not what we might have predicted, however. A lot of things have changed, although we've looked at early versus late when there was fewer medications, fewer of the new medications versus later on, and there was no difference in that when we divided it up like that. So the ICD did not help, okay? Now, the bad news is we weren't able to help those patients. From the point of view of AHS, I'm sure they were happy they didn't have to put in more devices, okay, because it costs money. Some of your centers are probably happy as well because it would have increased the number of devices and the time required for the various labs to put in devices. But the very sad thing is we were not able to reduce mortality by putting in an ICD. That's not to say that some of those patients did not have a cardiac arrest and were saved by the ICD. We did see that, and a number of them were very lucky to have the ICD. But overall, in the overall group, it did not make a significant difference. So the other good thing from your point of view, okay, is that in the near future, no one is going to come to you with a messy Holter that's all noise and ask you to do T-wave alternans or turbulence, okay? But we do know they're important markers. And what we have to do now, next slide. Keep going. Okay, this just says what I basically just said. So you can keep going to the next one. Okay, they're important markers. But the thing is, we weren't able to make a difference with respect to reducing cardiac mortality in this group of patients. So we have a lot of work to do to try to find out a better way of helping those individuals. It's not putting in an ICD. Do we have to, more medications may help, more other interventions that may be coming down the road might help, but putting in an ICD at the moment does not benefit those patients overall. And I think that was my last slide. Oh, okay. That just says the same thing. That we have to, I got ahead of the slides. I got tired of the slides. Okay, so that was the bottom line. Sometimes you don't need the slides. Okay, so I think I'll stop there and take any questions that you might have.
I have a question about T-wave airtiness. Okay, so I realized when I analyzed the Holters, the T-wave changes specifically after the PVC. Does it mean anything?
We haven't looked at that. It may, but we haven't looked at that. It wouldn't be surprising because the PVC, when we have a PVC, it means that different areas of the heart, they don't, if you think of the electrical system of the heart, okay, the conduction system, it's like being on the Autobahn. Everything activates within 80 to 90 milliseconds, okay? If you have a PVC, just like when you're pacing, it starts maybe in the lower left ventricle, and it's kind of on the cow path, okay? To get the whole heart activated, it may take 150, 160 milliseconds. You got a wide, ugly QRS. Well, just like depolarization is ugly looking,
No.
repolarization is ugly looking.
Okay, so I mean like after PVC,
Yes.
and then there's a relative compensatory pause,
Yes.
so it will become a normal beat, right?
Yes.
It's just that first beat after PVC,
Right.
the T wave changes.
Yes.
The rest of the T wave are normal.
Right, but the repolarization may have been affected by the PVC
Okay.
because all of the heart wasn't quite ready for the next QRS when it came to the repolarization, okay?
Okay.
So it can affect it. It could be repolarized at different times in different areas of the heart, and that would change the T wave. And that's why when we look at the T waves and we see that they're different in T wave alternans, that's what we think is going on. Different areas of the heart, possibly in the infarct area or peri-infarct area, are repolarizing at a different time than other areas.
Okay, thank you so much.
Any other questions? So let me ask, how many here were involved with Refine ICD or knew about it? Really? Oh, there's more hands going up. Okay. Were you surprised that the trial was negative? Yeah. Yeah. We were surprised. We were surprised as well, but when you think of all the new medications, although early on we didn't see a difference either. Okay, so we still got some work to do. Okay, no other questions? Okay, thank you for having me. Thank you. Sorry about the audio issue.
Thank you very much.
Okay, thank you.
Thank you so much, Dr. Kavanagh. We are very grateful for having you here at our inaugural symposium. We'll now have a couple of announcements from Sean and into the sponsors.
Hi, everyone. Once again, thanks for coming. I hope everyone's been satisfied so far with the presentations. I think we've had a good couple of speakers. Couple of announcements. First off, following this quick session, we'll be having a coffee break, and I want everyone to thank the ASRCT for sponsoring the coffee and snacks today. So thanks very much for your support. And secondly, I'd like everyone to thank our sponsors and their booths and the vendors we have in the back for coming in and sharing their information and their wares with us. Thanks again. Right now, we are going to have a quick 10 to 15 minute presentation from our platinum sponsor, who's Medtronic. I'd like to welcome Kevin Green to the stage to talk to you about their company. Thanks so much.
Okay, perfect. So I've met many of you over the years. I've been around for quite a long time. As it says on the slide, I am a former BCIT cardiology tech grad back in 1993, so I'm dating myself there, but I think we were in the... All right, I was in the first class from BCIT, so I've got a fondness for what you guys do. Certainly have experience with what you guys do. And I've been now with Medtronic for 23 years after working in an EP lab. So again, been around the block. Did my first pacemaker implant in 1994. So I'm just going to really provide a bit of a history of sort of the evolution of pacing and kind of where we're going. As the title says, you know, really the amount of change that we've seen in pacing in the last, let's call it 10 years, 7 to 10 years, is extraordinary compared to what we've seen in the past. But pacing's been around. Well, that picture is from 1958, and that's really where our company started. So Medtronic's the largest medical device company in the world, depending on how you measure it. Generally, it comes out as number 1. But we started as a pacemaker company. So that's a picture of Dr. Lillihei in Minneapolis, and our founder's first invention, which was a battery-powered external pacemaker. So that was back in 1958. It was developed because they used to be AC-powered, and then they had a power outage in Minneapolis, and they had a couple of patients who were connected to temporary pacemakers die because of the power outage. So he said, "Earl, make me a battery-powered one." Earl came back 24, 48 hours later with a sample, and the next day a patient was connected to it, and that's kind of where we started. Just advance. Next slide. All right. So this is, again, timeline of where we started. So 1958, first external pacemaker. 1960, first implantable pacemakers. Dual chambers started in 1989. And then acceleration, it shows there our first leadless pacemaker was 2016. Physiologic pacing or conduction system pacing started in about 2018, and then we got into some more advances moving forward. While there are some big gaps there, I will tell you from dual chamber pacing to leadless pacing making, there was a ton of innovation that happened in that 27-year period, but it was all based on advancing traditional core pacemakers, which is still the bulk of what are implanted, dual chamber pacemakers with 2 leads. But the advancements in pacing from 89 to now, it was quite extraordinary between features that were being added, so rate response, automaticity. All of the pacemakers now basically do every possible test that you would do in clinic for the past 40 years. Now the pacemakers do them automatically. So we continue to advance from the perspective of battery technology, making the pacemaker smaller, making them last longer, et cetera. But I'm going to focus really as we move forward, you could advance, to where we are going. So between leadless and conduction system pacing, and then kind of what is next. Because really, like I said, in the last decade, the amount of change and innovation is extraordinary. Advance. So really, again, these are the 3 areas of focus for us moving forward: leadless pacemaking, conduction system pacemaking, and getting into optimizing pacemaking. So pacemakers now, like I said, do a lot of the features, a lot of the things that we used to do in follow-up, they will do automatically. So now your role, when those of you who deal with pacemakers, really you become critical in terms of optimizing and tailoring that pacemaker for that individual patient. We're continuing to collect data, continuing to identify ways to best optimize them, especially now when we're talking about conduction system pacing and how to leverage that capture of the left bundle to really improve patient outcomes. Really, your role will be critical in terms of optimizing and tailoring that pacemaker for the individual patient as we move forward. Next slide. All right, so leadless. So our first leadless pacemaker was our first generation of Micra. It was a single chamber pacemaker, so VVI pacemaker. Some would ask, why leadless pacemakers? Why did we go down this route? The real reason is when we look at how to innovate or where we can innovate, is how do we reduce complications and how do we improve patient outcomes? So there are some patients who have vascular access issues from above. Normally we would implant a lead in the subclavian vein, but if they have occlusions on both sides in the subclavian system, there are really no options for those patients that were very good. Occasionally you'd go through the femoral vein, have to implant a pacemaker in the groin, much more complicated to do, very difficult to do. So leadless that's a very small niche, but there are other patients who have higher risks with a traditional pacemaker. So the limitation with a traditional pacemaker is still the leads. Leads are where we do have a greater degree of complications. Leads dislodge, leads can fracture. Now the quality of the leads, the quality of the technology is improving every generation, but still the leads are the biggest limitation. So if we remove the leads out of the equation, we could reduce complications. In addition, there are patients who have, who are very frail, elderly, high infection rate, very thin skin. They have very little tissue up here, the risk of erosion of a traditional pacemaker, risk of infection with a traditional pacemaker. So there are subsets of patients where a leadless pacemaker is the best option for that patient, and that's why we've developed leadless pacemakers. Patients love it, obviously. There's no visible signs of pacemaker. And for them, from a quality of life perspective, they tend to gravitate. If you give a patient a choice of a leadless pacemaker and a pacemaker that's going to leave a bump in their chest and what have you, they generally like the concept of a leadless pacemaker. So it was really about complications and reducing complications for pacemakers that we developed leadless. Next slide. So it's you come visit us back at the booth. We can show you the demos, but it's 93% smaller than a traditional pacemaker. Obviously, no leads, events. These devices now last about 17 years, so a single device, and again, this is where the battery technologies come into play. Single implant that lasts 17 years, and 80% of the patients with this newest generation of Micra will have one pacemaker for their lifespan. So again, the goal is to minimize changeouts and replacement of devices. The longer the device lasts, the more likely the patient is to have a single implant for the rest of their life. And it preserves vascular access should they need another device down the road. So if you have a younger patient, you put leads in somebody in their late teens and early 20s, the chances of that lead failing over their lifespan is very, very high. I mean, leads don't typically last 50, 60 years. So if you can put in a leadless device and get 15, 17 years out of it, then maybe they're getting their first lead at 45 years old or 50 years old, and you're able to preserve their vascular access for future needs down the road. Micras can be replaced or removed and replaced, but they're generally designed to be replaced and turned off. So if you have one the last 15 years, it's our only pacemaker that actually can be turned off. So most of our other pacemakers, or all of our other pacemakers, traditional pacemakers, you have to remove it because they cannot be turned off. You can turn the rate down low, but at the end of the day, when the battery fails, the device could start acting odd and cause issues down the road, so they need to come out. These ones can be programmed off. In addition, we estimate about 3 Micras in the average patient over the course of their lifetime, because it takes up about 1% of the RV space, or the RV chamber. One thing I'll note, for those of you who see pacemaker patients post-implant, Micra does not have a magnet mode, just an FYI. So many of you might do a magnet mode ECG post-implant. Micra is the only device of ours that does not have a magnet mode. So just be aware, if you're trying to put a magnet on and get a Micra to start pacing asynchronously, it will not do that. Next slide. And I'm not going to go into a lot of detail, but Micra AV, so one of the limitations of Micra when we first launched was it's a single chamber pacemaker. So in many patients who have sinus rhythm, you want to maintain AV synchrony. So if they have complete heart block, you want to maintain AV synchrony, so a single chamber pacemaker may not be ideal because you lose that AV synchrony component. Micro AV was developed somewhat fortuitously, so they were our engineers were trying to find a way to provide AV synchrony with our micro devices, and they were looking at different options to try and sense the atrium to pace the ventricle, so to provide AV synchrony with a sensed P wave. What they discovered is the accelerometer in the device, which measures patient activity, actually also recorded activity when the atrium contracted. So it's actually, they've developed an algorithm within the device that senses the atrial contraction, the mechanical atrial contraction of the atrium from the ventricle. So the implant's no different, physically the same device they implant, but it can sense the atrium and then pace the ventricle. So it provides AV synchrony. Next slide. Conduction system pacing. You're going to get a talk on this later. They're going to go into a lot more technical details. Does anybody know why conduction system pacing is as popular as it is right now? It is taking over. I've never seen anything like this in pacing in my 30 years of pacing, in terms of the passion the physicians have for a new innovation like this. Any thoughts as to why we would consider conduction system pacing? So think of a traditional pace complex. Everybody agree? Big and wide? Sorry? Was there a hand up over here? What was it? Exactly, exactly. Again, like I said, I was involved in pacemakers from '94 onwards. In the early days, we did not see any negative impact of pacing. We did not think, slow heart rate, put in a pacemaker, patient had conduction and sinus bradycardia, we'd still pace them, dual chamber, A and V, and have the big wide QRS. We didn't think we were doing anything to harm these patients. In the late 90s, I think it was 1998, the Danish trial came out and said, maybe we're doing a disservice to these patients. So then we spent a decade trying to refine algorithms and things in the devices to not pace the ventricle unless absolutely needed. At the end of the day, as you pointed out, the more you pace the right ventricle, the worse many patients do over time. From a perspective of AFib, developing atrial fibrillation, developing heart failure, the heart likes to conduct normally, which is through the conduction system, septum first, synchronized right and left ventricles. When you pace from the RV apex, it's pacing RV first, then LV, and then the LV depolarizes. So it's desynchronous. So desynchrony is a term we've heard a lot of in the last 20 years with CRT development, but essentially it's the same principle here. If you're going to pace the patient in the right ventricle, is there a better way to do it? And that's where the conduction system comes in. Next slide. You can advance. One more. So again, not all pacing is equal. So what we are doing with conduction system pacing, and you can try it, your hand on our simulator in the back later this afternoon, is we're trying to pace from the left bundle. We're actually screwing the lead in through the septum into the left bundle branch. And by doing that, we can capture the conduction system and create a much more concentric contraction, a much more synchronous contraction between the right and left ventricles. We're essentially using the highway that already exists, and we're pacing into it, and we're having the heart contract in a much more efficient way. The challenge for those of you who are seeing patients post-op is how do you tell that it's actually capturing? Because in many cases, these QRSs are very, very narrow, look very similar to an intrinsic QRS. So it becomes harder for you, when you're doing a post-op ECG to determine just by doing the ECG that things are capturing correctly. So really important to understand if the patient's getting a conduction system device, that their QRS may not look like what you're traditionally expecting to see from a paced QRS. Next slide. Again, you can advance that, but again, we know the conduction system reduces the risk of AFib and reduces the risk of developing heart failure over time. This is just an example of the lead that we use. So it's a 4 French lead, perfectly tailored to advancing through the septum and creating minimal issues in doing so. The challenge there is developing a lead that's going to, go back to the one with the video. is developing a lead that actually will sustain itself and survive in that environment. Most of these leads fix inside a chamber, and the screw takes all the torque. But in this case, so you can you get that video to play, or try to get that video to play? So this just shows some of the testing goes on. This is slowed down significantly. In real time, this is going rapidly. So we're doing millions of cycles to try and get that lead to bend as it would inside this in the septum to make sure it's going to survive. So that was really the challenge in developing technology to do this, is can we develop leads, or do we have leads that will survive in that location? And we do. Next slide. Procedure times are very similar now once the physicians get through the learning curve, which are relatively typically short. Chronic, stable, expectation in terms of thresholds and everything else, similar to what you would see with a traditional transvenous pacemaker. So thresholds under 1 volt. You can see average pace QRS in this study of 117 milliseconds, which again, a normal QRS is anything less than 120. So we're actually getting normal QRS durations with conduction system pacing, which is very different than what we would see with an RV apical paced heart. Next slide. So what's next? Next slide. So optimizing. Again, this is about, one of the things we're learning is, the general parameters of a pacemaker have not changed forever. Base rate is typically 60 beats per minute in the device, standard AV intervals, et cetera, et cetera, et cetera. But this is where you guys come in terms of how do we tailor these devices to optimize outcomes for these patients. One of the things our scientists are actually looking at is, a base rate of 60 may not be applicable to every patient. So there's a lot of thought now. We've got apparently good data, and this is the next sort of paradigm that we're looking at, is patients, depending on the size of the patient, which dictates size of heart, so smaller hearts might need higher resting heart rates. So my mom, who's 5'2", probably should have a resting heart rate of 70, whereas my dad, who's 6'4", 55 might be okay. But we've programmed all pacemakers at 60, and sometimes we'll lower it to 50, but it might not be appropriate for every patient. So these are the kind of things we're looking at as we move forward, is how do we tailor pacing to the individual patient. Next slide. Bachman's bundle. Everybody's heard of Bachman's bundle, knows what Bachman's bundle is. So this is the next boundary we're pushing. So this lead that we use for conduction system for pacing the left bundle can also be used for pacing Bachman's bundle. So there is a lot of work being done on Bachman's bundle pacing. Again, we talked about this 20 years ago. It died, now it's coming back. So it was originally looked at for atrial fib, pacing the Bachman's bundle, because the idea here is think of it as atrial dyssynchrony. So we talk a lot about pacing the right ventricle and ventricular dyssynchrony. This is no different. It's dyssynchrony of the atria. So if you pace Bachman's bundle, you're pacing the highway that conducts rapidly to the left atrium. You should shorten that P wave duration, because what happens is if you have delayed conduction through the atrium, the atrium on the left side is late to depolarize, late to contract, and you could actually have mitral regurgitation occurring as the ventricles start to contract before that left atrium is contracted. So we're actually looking at this. You can advance the slide. We're actually looking at this for patients who have, and you can advance again, HFpEF, so heart failure with preserved ejection fraction. There's thoughts that these patients may benefit from Bachman's bundle pacing. So actually here in Calgary, you're going to be participating in a trial. I think Dr. Ballantyne, who's speaking later this afternoon, is one of the participants in this, but they're going to be starting to implant leads in Bachman's bundle to sort of see how we treat these patients, or if that is an effective treatment for HFpEF patients, which, if you've ever seen a patient who has heart failure and preserved EF, there is very little options for those patients. Nothing seems to work great for them in terms of improving symptoms. So Bachman's bundle is kind of what we're looking at. And next slide. I think this might be it. Oh, and then finally, this is the last slide. So our holy grail, Medtronic's holy grail, and what we're trying to do, there's still limitations with leadless pacing, because we're pacing the septum, we're not pacing the conduction system. So we're still going to have a wider QRS than ideal. It's better than pacing the apex, but it's a challenge. It's still not ideal from a synchrony perspective. Then you've got conduction system pacing that still uses leads. So again, the complications that are lead associated don't go away. So our goal is to merge the two of them together and develop leadless pacing that also provides conduction systems. So our scientists are working on it. I've seen some of the cadaver and animal work that they're doing. It's really impressive. So within a couple of years, we'll start to see leadless pacemakers, micros that can be potentially implanted into the conduction system. So that's kind of where we're going next. And that's it. I don't know if there's time for questions. Do you want?
No, there's no time for questions.
Sorry.
Thanks again.
No worries.
Thanks
Right,
again.
very good.
Appreciate it. That's right. Thanks again, Kevin, and thanks again to Medtronic for supporting our event. Once again, I just want to point out that without the support of all of our sponsors, it would have been very hard to put this event together today. So once again. Okay, we're going to have a break for some coffee and snacks, and we'll be back with our next speaker at 11:15. We're gonna be good. Here, no, Evan, you got 5 minutes.
No
I'm
worries.
just gonna tell people to.
Oh, you're gonna tell them to
Yeah.
go get the last.
Yeah.
Well, Lynn's gonna try.
No, Lynn's gonna do it. Could we get everyone's attention, please, just to let everybody know we've got 5 minutes until the next speaker will be commencing. So, please grab your seats. Thanks.
Good to turn it off.
Yeah, exactly right. Check the other portal.
Yeah, no worries.
One more minute left. One more minute, everybody.
It's like me talking to my kids. Timing it all. Like, it's got bedtime's in 5 minutes, bedtime's in 3 minutes, bedtime's now. No, it doesn't happen at all. Then there's always like, I still have to go to the bathroom. It's like, oh, I didn't brush my teeth. They'll get better eventually, like when they're 20 or something. But I don't know if that ever happens. If they're ever, at least they won't admit it publicly that Dad was right, I'm sure. Maybe to other people, but never to me. Yeah. How are things? Life's good? La Bella Vie? Said La Bella Vie, the beautiful life? It's good. Okay, perfect. What's your role here today? What are you in charge of the education committee? Or just the conference, but not the Csct in general. Not the president, no, president. Not yet. Is it going to rotate? So somebody said it's going to go to Halifax next year. If you guys plan it out Yes, you can do the one-liner.
Is that okay?
Yeah.
I scratched it out. Okay, we are ready to get started. Everybody, please take your seats. I'm happy to announce that Dr. Evan Lockwood is a clinical professor of medicine and a cardiologist specializing in clinical cardiac electrophysiology, focusing on managing atrial fibrillation and preventing sudden cardiac death, and using cardiac resynchronization therapy for heart failure. And he has come to us graciously from Edmonton today, so welcome, Dr. Lockwood.
Excellent. All right. So I have presented to this group before. I know it's a non-hostile audience, which is really nice. In fact, the first Csct member I ever met was Karen Schaus, wherever she is, and she's at the back. 1998. I was a medical student at the time, and she came out to party with everybody. That's all I remember. So I've heard rumors she still does that. Yeah. All right. So today, no suit or tie, because I'm talking about AI, which is kind of a tech bro thing, so all in black. That's what's required. Those of you, I'm going to see, it was working. He's playing with my computer. He's still playing with it's going to work. One moment. We're all good. It's bad when you talk about technology and you can't make the technology work, but I won't be using, I hate when people have to say, are forced to say, next slide, next slide, next slide. So when I was young, growing up, the only part of artificial intelligence that I understood was Skynet. Does anybody know what Skynet's from? Thank you. Excellent. Good. The reference fell perfectly. So at that time, we'd kind of been given the fear of AI as something that was going to be a terrible process that was going to devastate the world. And unfortunately, that still is thought to be real. So this is a quote from somebody I don't have a whole hell of a lot of respect for, but still, it is actually been shown that there may be some potential bad things that come from AI, and we'll talk about that. But pioneers from AI have said there's about a 10 to 20% chance over the next 30 years that AI will lead to the end of civilization, which is a lot. I mean, it's a bit scaremongering and stuff, but there's a possibility. When I was a kid, this was what I thought was AI, okay? We all thought, there's no way you can beat this thing. It's totally random. Obviously, the computers are running the show. But in actual fact, it's just a pattern. So people were able to finish Pac-Man because it is actually a pattern. There is no AI involved. You could memorize the patterns, and then you could beat the game. This is different, though. This is what my kid's playing now. So NFL Madden football is completely AI. So every one of these players on this video game has been built from an actual model of the real human to do exactly what the human would do in those circumstances. So every time you play the game, it will never be exactly the same because it's learning and it's replicating that, okay? So AI is all around us. We're all using it. Our kids are using it, or we're using it in video games for exactly this reason. So now we're going to talk about the translation to medicine. Before I do that, I have to let you know there's a lot of money in AI. This is kind of the new crypto. So if you can get an AI project on the go, you can get venture capital or companies like Medtronic to buy into it and make a lot of money. This is a small island in the Caribbean, Anguilla. And those of you who know about domain registrations for websites know that you can buy a .com. So evanlockwood.com is out there. You can look it up. So is evanlockwood.ca, because I'm Canadian. But Anguilla got given .ai as their country code. They make $50 million a year because people register websites .ai. So evanlockwood.ai, I would have to pay them hundreds of dollars. And every company out there that wants to register a .ai has to go to their country and get it registered. And they're making, it's something around 50% of their annual income for the country is made from domain registrations right now every year. It's a poor country overall. Okay, Now we're going to switch gears. So we're going to talk about AI and cardiology. The dream that AI can reduce costs, make work productive so fewer staff are needed, triage patients faster, and ensure they're cared for in the right setting. That's what we're all hoping for. And this has been around for many years. This was a quote from several years ago. Unfortunately, you guys should all be concerned, as am I, about the need for fewer staff, okay? You are working in, as am I, an area where AI will impact the number of staff that are needed. And we'll talk about that shortly. There's going to be some key concepts that we're going to discuss today that relate to AI in medicine. So artificial intelligence, okay, where computers are made to learn and think just like humans, okay? In medicine, that would be helping doctors and nurses make decisions, manage patients. Machine learning, which is where they learn from seeing repetitive examples of things, just like a baby would learn. So you'd show them pictures of cats 10 times, eventually they figure out what a cat looks like, okay? Medical imaging, that's an area I tell medical students not to go into anymore, right? The idea that a human is going to be reading x-rays at some point is not going to happen in many years from now, right? When I tell people, a radiologist is probably trained on 5,000 chest x-rays. That's what their bank of reference is through 5 years of residency. They know what 5,000 normal x-rays or x-rays with cancer, whatever, look like. That's how many they've seen. A computer has 1.5 million that it can reference. So it knows exactly what normals look like. It knows what cancer looks like on a way larger number of demonstrations. And so it will always be faster, better, and it will never miss the subtle things that a physician misses because they haven't had their coffee, even if it's served in a Dixie cup. Okay? The goal of most of the AI things is predictive analytics. We'll talk about that, which is not to say what's happening now, but what's going to happen in the future. Okay? Based on these tests or what we've found, what information we've garnered, we can say what is your risk of X in 30 days, 1 year, 5 years, so on and so forth. Okay? A lot of it will involve electronic health record analysis, so going through things like Epic. Those of you who may work in institutions that use Epic will have that benefit. Okay? There are 3 types of tools that we use in AI. As I mentioned, machine learning, which is like a toddler learning from examples. Over and over again, you kind of beat it to death. Deep learning is what adults do. We process it. We take information from many sources, we put it together, and then we make predictions or plans from that. And then large language models, many of you, if not all of you, are using those now. So the best example of that is Csct. It's probably the most public one. It's only been out for a few years, at least for common use. And we'll mention how that's involved in medicine right now. Okay, this is a complicated concept that I'm going to mention now. The idea of a foundational model is, it's been around for about 5 years, and it is how they take tons of data. When I say tons, I mean millions and millions, up to billions of points of data are literally thrown at computers, and they process it. And it's not labeled. It could literally be all of our demographics, every ECG you guys have ever done, all in one database, just stuffed in there, and it's not told what they are. It's just like, all it sees is pink lines, which is just an image to it, and it just sees it over and over and over again. And it has to figure out what those mean, okay? So that's the foundation. It gets all this unlabeled, completely anonymous, random data, and the computers figure out that that's an ECG. And they figure out that there's a little blip before the tall, sharp blip, before the kind of low frequency, longer blip. And that looks like, that's the pattern I see most of the time. Then we take all of that data and what it's learned from that, it's figured out that's an ECG, okay? Then we compare that to a bunch of labeled data, which would be an example of, here's a database for which I've interpreted the ECGs. This is an example of sinus rhythm. That's the gold standard, sinus rhythm. And then it compares all the ones it's seen, the millions of ECGs, to the one that I've labeled as sinus rhythm. It figures out, all those data points, that was sinus rhythm. I figured it out. So these things are absolutely brilliant. It can do it for coding, it can do it for reference textbooks, everything. It takes all the data, okay? If you think about programs like ChatGPT, did you know that they are out of information? They have read the internet. They've read every textbook ever published. They've read every newspaper article ever published. There is no more data for these things. They're full. So they want more data. And we'll talk about how the limitations of these AI are because it is out of information. Okay. So an example here. If we look at ECG analysis for arrhythmia detection, what we're going to get is we're going to get all the ECGs dumped in. So say the Philips database or Muse. I saw Muse as one of our supporters today. So all of the Muse ECGs that have ever been done are dumped into a database. And then we compare them to what AFib looks like. Now, the computer doesn't know what AFib is, but it knows that every once in a while these patterns are not regular, it's irregular. Then we tell it that was AFib, and now it can figure out every time it sees that pattern what AFib is. But it can also see other things, and we'll mention those in a moment too. Okay, these are the large language models that many of you may be familiar with. Okay, ChatGPT became publicly available just about 2-3 years ago. Cloud is the other one. Depending on what your needs are, these are the kind of the three things. I don't usually recommend Grok only because I don't like supporting Elon, but that's his project as well. It's the one that had a lot of problems with like the Nazi stuff, so maybe skip that one. But ChatGPT and Cloud are both excellent programs. I don't Google things anymore. I don't use Google. My kid doesn't use Google. Most of the people I recommend to don't Google things anymore. If you put it into one of these, it'll actually go to the internet and get the information, but it'll summarize it. You don't get any ads. So pretty slick. Okay. If you want to make images now, so faking images, you can use any of these programs. So DALL-E is a program built into ChatGPT, and if you want it to create an image, you'll just tell it, create me an image of a flower, and it will do so. Same thing with Midjourney, which was kind of the original one, and then Firefly is an Adobe program. So for example, this is what I typed in. Create an image of a cardiologist delivering a lecture in a hospital amphitheater. That's what it created. I gave it no other clues, just that one simple sentence, and each company gives a little bit different spin. And I'm sure if I'd have said I was a respirologist, it would have put a lung up there instead of a heart. But it's not bad, right? And you can actually take my image as a reference image and say, this guy, this random person, make him the person presenting the lecture. And it would take my face and roughly my form, okay? I asked it to create an image of a cardiac electrophysiologist. And I was like, that's pretty close. That's how I feel most days at work, pretty powerful. And I said, what about an interventional cardiologist? And it was like, yeah. So that's kind of what I think they look like too. All right. My first application of AI was when ChatGPT first came out. I was like, how can I use this? It seems pretty slick. And I was asked to give a talk for ultrasound techs at the hospital. And they said, talk about ECGs. I'm like, what? You guys don't use ECGs. What am I supposed to talk about? So I asked ChatGPT, create an outline, not the slides, but create an outline of a presentation that I can use for these ultrasound techs. They need to know basics. So it created a perfect outline, where is it, of what I need to talk about. And they loved it. And I confessed to them that I didn't come up with the outline. I made the slides, but this is several years ago. Now I don't even need to make the slides. I could have said to it, give me 25 slides on this topic with bullet points, add some funny anecdotes, put some cartoons in, and format them using this font and this background. And it would have done the whole thing for me. I didn't have to do any work. I did do this one, just to be clear, this is mine. Okay, so how about in cardiology, okay? So how about in my day-to-day life? I work on the wards, I would do coverage in the CCU at nights. Well, you can do clinical decision support, so we have things like, I want a literature summary. I want to know what the latest is on some dermatological issue I know nothing about, but that's what my patient has, and I don't know, that's outside of my area, okay? You can ask for guideline highlights. One of the things we tested one day was, what are the driving restrictions after a heart attack? And it gave us the restrictions, and I was like, I don't know if that's right. One of the most powerful things you can do with these ChatGPT and the other LLMs is you ask it, are you sure? Well, it turns out it gave me the guidelines from 2 guidelines ago. So we were like, that doesn't seem right. Are you sure? So we type in, are you sure? And it says, I made a mistake. I'm so sorry. I did not include the 2023 guidelines in driving. Here's the up-to-date version. I'm like, thank you. Okay. Can help you in differential diagnosis, right? If you forget what the top 10 things causing chest pain are, then it can give you the bottom 7. You probably remember the top 3. At least I would hope I would remember the top 3. Okay? Communication tools for patients. Okay? You want to explain somebody, this is a farmer from Redwater, Alberta, small town, who has a grade 6 education. Explain to him what a heart attack is. It will print out a little handout we can give to him so he can learn what a heart attack is and understand it better. As opposed to the professor in exercise physiology from the University of Alberta, he's going to want a different explanation. So we can explain things to him, and they will create the tools that we can give to the patients. You can have a scribe. So many people are using this right now. It was actually pioneered at the University of Alberta. We have a very powerful AI group outside of medicine, but within the faculty. And they have a program, and it is called Scribe, and it will take dictation. So you will actually have it open while you're talking to a patient. It will take all the information that you two banter back and forth. Then it summarizes it and puts it into the clinical chart. No typing. Nobody standing there having to take notes or anything like that. You can actually make eye contact with your physician. Right now, I don't know if any of you work or go to see a family physician or whatever that's got an electronic medical record. They stare at the computer. They don't even look at you because they have to type everything in. They're required to put all the documentation in. Well, you can get rid of that with AI, and it will summarize it for them. Okay? There's some workflow efficiencies you can get out of in terms of optimizing things that records and stuff like that. Education, which is like the rounds that I did for those ultrasound techs. And then research assistance, right? You can dump in you can ask it to collect all of the papers on atrial fibrillation that have been published in the last 3 years related to the ablation procedures in white males aged 50 to 60 and what the best strategies would be. And it will summarize all that and give me the answer, and then I can be like, oh, okay, that's interesting. That's how I can apply that in my practice. Medical vernaculars out there. So we struggle all the time. We have I work at the downtown hospital in Edmonton. We have a United Nations of patients who come in, okay? We have a fairly strong immigrant population around us, and I barely speak English, but that's the only language I speak, but these patients come in speaking many languages. We can actually go back and forth using these LLMs, like Csct, without having to call in a translation service. We can translate everything we do into one of these other languages. You can see there on the left, most of the common ones. Okay? When did AI in medicine actually start? Does anybody know who this is? You are the audience who has the best chance of knowing who he is. Not from Alberta. Utah. Okay, 1957, he's the guy who came up with, not the ECG, but he's the guy who came up with, let's put an interpretation on there. Let's let the computers figure out what it is. So the preliminary interpretations at the top of every ECG, it says sinus rhythm or consider acute infarct. That was his baby, 1957. So that was the first version we taught computers how to do basic interpretations of ECGs. Now we have programs like this. This is something, and I tested it out. Don't pay for it. Please don't pay for it. It's very expensive. But it's an app where you actually take a picture of a 12-lead ECG, and it will give you the diagnosis. So you just have to have it printed out or on a computer screen. This one's giving you a diagnosis. Basically, it's replacing me, but that's okay. I got lots of work. Okay. Now I'm going to show you a bunch of data, and it's basically to show you the power of AI tools in cardiology. Okay. This is I have to show you this graph only because it's going to teach you guys how to look at the pictures I'm going to show you. So you want blue lines. When I'm showing you research to show is AI any good at detecting things or predicting things, if the graph I show you has a line that looks like the blue one, so kind of squished up to the top left-hand corner, that's good. If it has a flat line like the yellow one, that's no good. Okay? So AI tools that have yellow lines, throw those ones out. AI tools that have blue lines, which shows you that it's a sensitive test, so it doesn't miss anything, and it's a specific test, it's always right. That gives you a nice blue line, okay? This is an ECG from a 50-year-old cardiologist. You guys do lots and lots of these. I read 1,000 of them yesterday before I drove here, okay? So a lot of ECGs. That software, and I'm looking at you guys in the back there, Muse, that software has not changed since I started on staff. It has not been updated. I should have been replaced years ago. Right? This is a lot of work reading ECGs, confirm, change this is not LVH, this is AFib, this is not an infarct. Going back and editing all these things. These computer technologies are no better now than they were 15 years ago because nobody's willing to pay to update them. But I could be replaced tomorrow and it would read this ECG and say this one's normal. It's fine. Okay? An ECG can tell you what happened in the past, so it'll say, you've had an infarct. It can tell you what's happening right now, you have AFib. But it's no good. This version, the current Muse NX version, is no good at telling you the future. But there are programs out there that can, from this exact snapshot, it can predict the future. Okay. You can predict somebody's risk of atrial fibrillation from an ECG in sinus rhythm. So we take a picture of the ECG, and they worked backwards, and they say, okay, we've got all these people that developed AFib. Let's go back and look at their ECGs. And they dumped in literally millions of ECGs. They went backwards, and they said, from that ECG that was taken 2 weeks ago or 2 months ago, we could have predicted this person had AFib. And you'll notice those curves on the right-hand side there, they look pretty much like the blue one I showed you before. So this program, pretty darn good at predicting Who's going to develop AFib from an ECG in sinus, just like mine, just like that ECG? And I have that AFib. Okay, can we do even better with an ECG? So ECG FM stands for ECG Foundational Model. Remember I mentioned at the beginning, if you dump millions, literally tens of millions of ECGs into a database, process them, you can figure out some secret things that we don't see when we interpret them and say there's LVH or AFib or enlarged left atrium, okay? And they compared that, they added that ECG data to data about troponins and data from echocardiograms. And you were able to, and I don't have the pictures for this one, you can predict from this ECG program, one snapshot, single ECG in sinus rhythm, what the ejection fraction is. Okay? You can predict whether or not it's under 30%, under 40%, or under 50% with pretty darn good accuracy. You can also predict many other things on the ECG, hypertension, or LVH, etc. But you could also predict their troponin levels. You could guess how big of an infarct somebody was having from an ECG in sinus rhythm. You could say this person has an N-STEMI, right? You don't know what the troponin is. The ECG looks normal. But from subtle things that I can't see, but the computers see, it can say the troponin was 250. That person probably should be admitted for N-STEMI ACS management. Okay? A single ECG can predict your EF. This is a program that is probably a little easier to use, can predict whether or not your ejection fraction is normal. Just flat out 12-lead ECG, run it through the software, it says ECG is normal. How would this be used in our hospitals? Well, everybody who gets an angiogram and has a small infarct gets a PCI. We have to sit them in the hospital for days waiting for that echocardiogram to get done. Some places are better, they can turn it around in 5 or 6 hours. Some hospitals it's going to take a couple of days. But if you could tell from the ECG done post-PCI, their EF's normal. What? Yeah, exactly. Any questions? No, I'm just kidding. It's unplugged. Okay. All right. As I said, if we could do an ECG post-PCI and say EF's normal, send them home, do an echo as an outpatient, we could save literally hundreds of thousands of dollars a year on people who are staying in hospital for inappropriate echoes because the echo done 2 days later is normal. We didn't need to keep them here. We could have known that from a 12-lead ECG done immediately post-PCI. Okay. This is one using echo data, and it was basically, can we evaluate how good are echoes at picking up all of these different things? Okay, so this was ECG plus echo. So they said, if we take the ECG, can the ECG predict on the millions and millions of data points, can it predict structural heart disease, poor ejection fractions, aortic stenosis, aortic regurgitation, things that you normally only see on an echo or by auscultating, right? Things you wouldn't normally expect to pick up on an ECG particularly. And it is pretty darn good. Some of the things are better than others. You can see some of those curves push more to the upper left. Some of them are a little flatter. So it's not perfect by any means. But when they asked physicians, they said, well, AI may be good, but I am clearly better. I can predict on an ECG whether or not this person has aortic stenosis. We do not need the machines. Well, the machines are far better. In fact, the machines are better than if the cardiologist gets involved and screws things up. So if you look here, on the left-hand side, the blue ones are if you let the cardiologist make a decision about whether or not there's aortic stenosis. If you tell the cardiologist what the computer said, it will be like, okay, some of that's right, but some of that's wrong. I disagree. Well, the cardiologist is not as good. If you just remove the physicians and you let the AI take over, it actually did the best. The AI alone, looking at the ECG, can predict aortic stenosis, aortic regurg, mitral regurg, ejection fractions better than I can. I know. On that, as a side note, anybody here ever been in a self-driving car? Would you buy one? No. Why not? No, exactly. That's the wrong answer. Wrong answer. Okay. All right. None of us are better drivers than a computer. We all get tired. We get distracted. We have kids screaming in the back. We're looking at the pretty girl or boy who walks down the street past us. Everything happens. Computers never have that problem, right? The only problem is in Alberta, we get snow. So it can't see the lines, can't see the parking meters or the curbs. So in Alberta, maybe not the best yet, but in any other jurisdiction without snow, a computer is going to be a far better driver than all of us. And we see in the news that we say, oh, that computer, there was a car accident in Phoenix. There was one accident, somebody got killed. They forget to tell you that 300 other people died that day in Arizona from human-driven car accidents, right? They always say the one computer one, which was almost always usually because a person walked out in front of the car. Anyway, anytime I think when people say I'm better than the machines, I'm like, maybe not. Not at everything, certainly not driving, or as it turns out, reading ECGs. Okay, what if we could predict your age from an ECG? So I would like to think that the AI would predict that I am a 40-year-old male, which it can do. It compares me to all the other 40-year-olds. I'm not 40, by the way, that ship sailed. But I would like to think that my AI-generated heart age would be 40 years old, which would be good, because I would have a better mortality and morbidity as a result. AI can look at our ECGs and say, actually, Evan, you've got the heart of a 60-year-old male, and your mortality is quite a bit higher than it should be. You need to make some changes. From a single ECG, it can tell you what your predicted age is based on just a 12-lead ECG and sinus rhythm. What if we can go even further? Forget figuring out conditions. Let's figure out if you're going to die, right? Which is really what we mostly care about, right? Most of us don't really care if we get aortic stenosis. We care whether or not we're going to be dead in 30 days. The computers are pretty good at that from a single ECG. It can predict your mortality here. 3 days, 7 days, 30 days, 60 days, 90 days, 1 year. You notice it gets a bit flatter as it goes further out because it can't predict all the other things in life. But from that single ECG, it can tell you what your chances of dying in 30 days are. Probably most of you are going to have an ECG on Monday, I bet. It can also do risk stratification of other things, common conditions. So it can tell you if somebody has HOCM better than we can as a physician, whether you have amyloid, aortic stenosis, I mentioned before, pulmonary hypertension, or long QT. It can predict which long QT syndrome you have, because certain medications don't work in certain long QT syndromes. So you'd like to know which one of those many types you have, and the AI is much better than humans at guessing that. Now, what about your Apple Watch? Okay, so my Apple Watch, many of us, or some of us will have them, or Fitbits or Garmin's or whatever it happens to be. They're pretty good at figuring out arrhythmias. When it looks at this rhythm, which you guys will all recognize is irregularly irregular, right? But is it irregularly irregular because of AFib? No, it's because of my PVCs. My 34,000 PVCs that I have some days. So it thinks this is AFib. No, it was actually pretty darn good at it. It said not AFib. Now what about this one? If you said it was just rate, this is my other one. Pretty fast. Lots of programs would say, oh, it's pretty fast. Maybe it's a little irregular, probably AFib. Nope, the Apple Watch AI built in said this is not AFib. It's my SVT, but it's not AFib. If you actually look at wearables, this is not an Apple Watch, this is a different version, but if you look at wearables, every time they ask cardiologists whether they're better than a wearable at detecting arrhythmias, we're not, right? It is actually better for the machines to pick up and detect AFib than for me to look at a 12-lead ECG. I mean, not me per se, but other cardiologists. Not Dr. Kavanaaugh either, who I didn't even get to thank. She was actually, when I started training, my first rotation in cardiology was with Dr. Kavanaaugh in Edmonton before she left. And at the time, she was trying to explain electrophysiology to me, and I said, I don't get it. I never will. I'm not doing this. It came back to bite me. She had a retirement event. She was honored as the mentor of the year for the Canadian Heart Rhythm Society a few weeks ago in Halifax, and I came up and told her that little story. I'm like, oops, I was wrong. Just like I would be wrong with reading ECGs. The wearable technology is actually better than humans at reading. Okay, so one of the problems is patients come in with all this wearable stuff. We get faxes, emails, all sorts of things with, here's what my Apple Watch said, here's a strip from my Fitbit, this is what this showed. We have no good way of processing it, so we can't run it through any of the AI. we can't collect any of it. It doesn't go into our electronic medical records. So we have a bit of an infrastructure problem at getting patient data into the software where it can be processed by AI to determine some of these things, but that's going to be coming. Okay, what about handheld echo? If I said about AI and handheld echo, well, this was a study that was done in oncology patients, and they basically gave a handheld echo with AI, and they let the oncology nurses use it, and they were just as good as the cardiologist at picking up whether or not the ejection fractions were no good. They put it on, and the AI said, no, it's fine, or the EF's down, as compared to a cardiologist looking at the images and trying to figure it out. So the AI is already out there and available. Angiograms, not a lot of research in angiograms, okay? It can predict, though. So normally, those of you who've seen an angiogram done, the coronaries are independent of the ventriculogram. So at the end of shooting the 3 coronaries, they'll often pile a dye into the ventricle, you see it squeeze, and then they can guess the ejection fraction from that. Well, they've actually done a study that said you can skip that part. Patients don't need the extra dye in the ventricles. Just from the tiny little amount that you put down the LAD, you can actually guess the ejection fraction whether or not it's over or under 40% with a single angiogram of one vessel, which is superficial, right? It does not, it's on the outside. It's not on the inside. It doesn't tell you how thick the muscle is, how well it's pumping, but they can predict on how it moves what your ejection fraction is. CT is way further ahead. As I mentioned, diagnostic imaging is probably a dying specialty, and at least true diagnostic, they're going to be better at integrating AI than anyone because they're highly motivated. They're literally, their careers and livelihoods depend on it. So there's lots of good stuff out there. This is a fat attenuation index. It can actually look at the amount of fat on your on your CT scan and predict your cardiac risk, whether or not you're going to have an infarct or a stroke or an ACS event in the next 30 days. They can do so many more things. They can predict how much. So if you've seen a CT scan, it's luminography. It's the same as an angiogram, right? So luminography means they shoot the dye down. It just shows you what the middle of the tube looks like. It does not show you how thick the cholesterol plaques are running through the entire coronary, okay? Because it can be really thick, but the lumen can look perfectly smooth and fine. But it doesn't tell you all this spongy, cholesterol-filled plaque that's sitting there. So what they've been able to do is they can predict how much restriction of flow is based on processing angiograms, and they can tell you exactly if that's a significant lesion or not based on the CT scan. You don't need to do an angiogram. You can predict exactly who should go for a PCI based on the flow, even when it looks normal. They can detect the flow going through that vessel based on CT. If anybody's ever seen TAVIs done, so before every TAVI that gets done for aortic stenosis, they will have to do an angiogram, and that's because they need to know if they've got a valve stenosis plus coronary artery disease, or probably historically you'd send them for open heart surgery. They get an open heart valve and they get bypass surgery. Well, instead of sending patients off for the angiogram, they can just do a CT scan. The CT scan checks to make sure a TAVI is appropriate because you can get through the vessels in the body, and then they also make sure that the coronaries are fine, and then they send these 90-year-olds off for their TAVI with very limited exposure to dye and very low risk. How about just from a picture of your face? So if we actually take pictures of everybody's face, which we'll be doing during the lunch hour, and then submitting them to this AI, you can actually predict your event rate based on your face. Okay? So it depends which area, whether it's your cheek or your forehead, but each little area, if you combine them, it can actually tell you, depending on how many areas are abnormal on this software, it can predict how many coronary artery blockages you've got. Whether you've got three vessel stenosis or not, based on just a picture of your face and an analysis of different regions, which is pretty cool, right? It's pretty neat. Now, my area of interest and expertise is in arrhythmia management, as Ellen mentioned at the very beginning. Right now, we do AF ablation in a pretty standard form. Most of us are doing a type of ablation called PFA now, which is a modification or evolution of our technologies from radiofrequency, which is burning, to cryo, which was freezing, and now we're doing basically little micro shocks inside the heart to treat AFib. Okay? And we do a standard practice. We do blah, blah, blah. We do 4 places, we get out. The whole procedure takes 60 minutes, okay? But what they actually were able to say is, what if we let AI look at some MRIs or CT scans or mapping of the heart first? And we say, well, let's compare what you normally do to what you normally do, but what the computer thinks you should do extra. So go ahead and do your normal stuff. And then they randomized everybody, and they said, what if you add a little little zap over here and put one down there and one over here, is it going to make a difference? Sure as hell it made a huge difference. And this is one of 2 studies. The other study I didn't put on the slide thing was even more dramatic. If you let the computers tell you where to go extra beyond what you do normally, the outcomes are vastly different, vastly improved. And like I said, we can make some predictions afterwards. So patients going into the procedure have a certain cardiac age. So their ECG says, oh, you're a 50-year-old male. And then after your ablation, if it reanalyzes your ECG and says, Evan, your ECG now shows you're a 40-year-old male, that's predictive of a very successful procedure, as opposed to you're still a 50-year-old guy, your ECG still looks like crap, right? I'm probably not going to have a good outcome from the procedure. Now, the most powerful thing that can come from all of this, so AI and cardiology, all of what I've talked about is diagnostic testing and stuff like that. These are all software packages that somebody can buy, and we can apply them at basically any time. Many of them are commercially available in small places, often in Europe. But the next thing that we want to do is become a digital twin. So what a digital twin is you take all of the data related to a person and you dump it into, let's say, into the computer, okay? So every blood test you've ever had, pictures of your face, every ECG you've had, every imaging bit you've had, every chest x-ray, CT scan, plus all the information from your wearable tech. So you upload everything from your Apple Watch or whatever other thing you do to monitor your heart rate. It all goes in and they create a digital Evan, okay? And from that digital Evan, they can now run tests and see what happens afterwards. So we can run things on digital Evan that we can't do on Evan. Now, the best example of that would be, what if I get cancer? And we're like, okay, we've got 3 different cancer things that we can use to treat, 3 different regimes. And we want to decide whether drug A, drug B, or drug C is going to be the best for them. Rather than give me toxic drug A, oh shit, that one didn't work. Toxic drug B, oh shit, that didn't work. Finally, 6 months later, we get to toxic drug C, that one worked. What if we just ran them through the digital thing? What if we just took digital Evan and we gave him all 3 drugs and we see what happens based on the predictive ability of my digital twin and say, what's going to turn out? And they'll be like, skip A, skip B, go straight to C. That's the one that's going to make the biggest difference. Then we give Evan drug C and we see what happens, okay? So that's the dream, is that we would all have a digital twin built in the system somewhere. So we could tell whether or not you were going to have cramps from cholesterol medications. Are you going to be statin intolerant? Are you going to be somebody who we give Plavix to who doesn't actually work as an antiplatelet for you and your stent blocks? Or are you going to be the person who needs to be on Ticlet or something else, some other novel antiplatelet drug because the other ones don't work for you? Or you're a warfarin hypersensitivity. So instead of needing 5 milligrams of warfarin, you need 1, or you're going to bleed out of your eyes, right? It'd be nice to know that before you get started trying these things out on patients. So here's an example. Okay, you can kind of guess what's been going on with Evan along the way. You get illness, you get better, you get illness, you get better, but I didn't recover. Well, we got to try and figure out what's going to happen. What can we do differently to change my trajectory with my health? Now, next thing is on devices. You're going to hear a little bit about devices a little later today. What if we were able to take a CT scan of somebody's heart and say, okay, we have 3 choices of veins to put that lead into. What's going to happen to the ejection fraction based on each of these 3 spots? Well, right now, what we would do is we'd put the wire, what we could do, not what we do. We could put the wire in each vein, and we could get an echo out, and we could see if the heart pump changes how strong it's going to beat after we pace in that particular location. And then we're like, oh, it didn't work, try the next one. Oh, it didn't work, try the next one. And we could keep trying spots to see which one eventually works. But if we could just make a model of somebody's heart from a CT scan they had the day before, we'd be like, skip those ones. We can make this procedure a lot faster. We just stick it in the one that's going to make the biggest difference, because we already know that his heart's going to pump the best based on putting the lead there. And he never had to have anything done. We didn't have to have a 3-hour procedure. We had a 30-minute procedure. We put the lead exactly where it was supposed to go the first time because we know that's what's going to make the biggest difference. Now, are there limitations to AI? Oh, yeah, many limitations. Okay, one of the biggest issues, something that I feel pretty strongly about, medical reversals. So whenever we're taking all of this data, so every research study that was wrong, okay, so those of you that have enough gray hair may remember a time when we said every woman over a certain age needs to be on hormone replacement therapy to prevent coronary artery disease, et cetera, et cetera. We were wrong, but at the time that was standard of care. Those were guidelines. All those papers are out there. And remember how I mentioned at the beginning that those large language models are swallowing up all the data? They pick up all the wrong stuff too. All the things we figure out 5 years, 10 years later, oops, we were wrong. It's in there. And it's using it as a reference because it didn't know any better. It assumed everything that's been published is kind of true, right? Another good example that we see in arrhythmias is class 1 antiarrhythmics were used to suppress PVCs. It was the CAST trial. So after you had a heart attack, they would count the number of PVCs. If you had too many PVCs, they said, well, we need to knock those number of PVCs down. We'll use antiarrhythmic drugs. And they were the drugs, flecainide, which is still used, econide, which is not used, but flecainide, excellent at knocking down PVCs. Also excellent at killing people post-MI who had PVCs, okay? But for years, that was the standard of care, was to use these drugs after an infarct. Well, then we were wrong, so then we stopped, right? And we don't use them anymore. But if you trained all of your models on something that was wrong, and that's 25, 30 years ago, but what about something that we developed today that research says today we think is right, but we find out in a year we were wrong? Well, all of the information it's built into, it's swallowed that up, it's processed it, it's now applying those things to advice that it may be giving out in 5 or 10 years. And it was based on wrong information. So that's one risk that can happen, whether it's fatty acids for fish oils for primary prevention, vitamin D for primary prevention, which both have been busted recently. So we do have some mistakes that can happen. There's also lots of information out there. There's lots of complexity, right? I don't know how many of you use an electronic medical record or have to be involved in them, but our one in Edmonton or one in Alberta is absolute garbage for the most part. It's a great place to enter orders, but the actual information in there is terrible. We don't have the same standards that are required by many American systems, which require you to have proper, clean data in their history, right? You don't have in the history arrhythmia, then A-fib, then atrial fib, then atrial-fib, all those things. They just muddy the waters, and the computers have to make sense of all that. In the US, you're actually required to clean all that up. So if you put a bunch of crap into an electronic medical record and your system is sweeping that up, it just creates garbage out. It's like every computer. So this is our hope. We hope that we can take all of our data from every one of us, all of the information that we've gathered from testing, from personalized wearables, et cetera, we can put it into a system that will then create potentially a digital twin which allows us to guess what our health's going to be, make predictions, and to tailor treatments that are specific for us. Okay? The real goal of all of this is personalized medicine, right? None of us is, unless you have an identical twin, there is no person just like you who's going to react the same way you do to testing or to medications or other therapies. And so you'd like to think that the use of AI will allow us to tailor specifically to you. One of the examples just came out this week, and the biggest problem with doing this talk, and I've done it several times, is that every time I do it, I have to go back and pull out the stuff that they've changed and add the new things in that have been updated since then. Okay? So it is changing all the time. Last time I did this was in May, and there have been so many new studies that have come out. And this is one that says we can actually take all the information of people on with atrial fibrillation and determine whether or not they should be anticoagulated. And they were actually able to take almost 40,000 patients and analyze them, and a whole pile of those patients, almost 20% of them, that were told they should be on anticoagulants because their benefit, preventing a stroke, would outweigh their risk of bleeding, were wrong. They shouldn't have been on them, because in that individual patient, using our scoring systems that we've been using for 20 years doesn't apply, right? Their risk of bleeding isn't accounted for on our traditional models. So having models that look at more data than what we currently use, CHADS, what's their ejection fraction? Do they have hypertension? Do they have diabetes? Are they over 65? Have they ever had a stroke or TIA? That's what we use right now. That's pretty basic, right? We have a lot more information available right now. So we can use that and say, you know what, these people, we can actually decide who gets anticoagulated with a little bit more granular detail. So this is just for those who are using Epic around the country. So Epic just announced that they're going to do their own AI thing. So we have not seen this. This is in the US in a pilot, but they are going to start literally combing the data in our medical records that we have and providing predictions. Like, what is the person's 30-day prediction of a COPD exacerbation or of an infarct or of a hospitalization for AFib or something like that. So that's all going to be available to us built into our electronic medical record that we currently have. So is this stuff cool? Is this hip? Is this new? Yes. They're actually looking for people. So even the University of Calgary is looking to hire a professor in AI in medicine. Like there are jobs for these people who become experts in this, and it's to apply it in medicine because we're at the forefront A lot of this is research-based, but it is becoming clinically applicable, and we want to be able to use these tools appropriately. So, this is probably my final word. By far, the greatest danger of AI is that people conclude too early that they understand it. So, I default to Skynet. Any questions? Sure, fire away. You're still not as good as an AI driving car.
I know. So here's my question, like you talked about the limitations of the wrong data and how are they going to get over that, being part of the generation of predictions and
Yeah, so they don't have a lot of good ideas about that one because we don't know what we don't know, right? We don't know what we're wrong about until we are.
Yeah.
So it gets permeated like a cancer through all of their results over time, and then it's hard to go back in and remove that information, but that's what you'd have to do is line by line make sure that, okay, every time we said to use flecainide after a heart attack to get rid of PVCs, yep, take that out, take that out, take that out. So it'd be a lot of work, but we don't have a good answer for that. The other thing I just wanted to mention on that one is when I said that it's read all the internet, it's read all the books, all the articles, so one of the risks is that it starts to make up new information because it wants to feed itself. It wants more data. So it's like it might start making up stories. Or it's like it starts, that's why I had the picture of the snake eating its tail, is that it starts to process AI-generated articles, right? So if you have an AI-generated article made by Csct, and now it references its own article, and then it references its own article, and you can make negative feedback loops just as often as you can make positive feedback loops.
Okay, my second question is all those bad quality, incorrect ECGs, Holter hookups, how do they affect the data that's collected?
Like the artifact?
Yeah, like you get some really bad, or even just reverse limb leads, you know.
Yeah, so it picks, so I mean, if you look at the tops of ECGs, it's pretty darn good at picking up reverse limb lead. Most of the time, I would say that's a pretty good one.
Yeah.
Artifact, it's crap at, and I change AFib all the time. But I think one of the problems is that the preliminary interpretations we get now are based on data or on training models from 20 years ago. They're not relevant anymore. So the new models are going to pick that up, and they're going to say this is artifact, or I spotted 2 P waves in lead 1, the rest of it's crap. I can tell you it's still sinus rhythm. So it's going to do a good job of that, whereas I'm going to tell you, redo the ECG. Right? Go back and do it again. And Holter's the same thing. But anytime you have crap in, you're going to get crap out. It's just going to reject all those. Do it again. Fix it. Or it's going to find some small detail, one beat, that it can analyze and says, well, it's probably ST elevation in the inferior leads. If this person's having a history of chest pain, and I've looked at its record to say the troponins were up, this is probably relevant of an infarct.
Okay.
So it has all the data.
All right, thank you.
One other thing that's interesting about these is they can do triage. So we get letters sent in from family doctors all the time, and they say, you know, this old person has AFib. Can you please see them? We put them on the list. Here in Calgary, that would take you a year. In Edmonton, I can see them in 90 days. But there are certain things it can read in in the triage notes by scanning it. It can say, well, this person has had a TIA a week ago or a stroke recently and is really high risk, and we should see them sooner, or they have some other features. Like it can change triage patterns as well just by reviewing records. Go ahead. Yeah.
Hospitals and clinics start to implement some of the AI-based ECG reading programs that you've mentioned?
Yeah, so none of them are commercially available right now in Edmonton or Alberta or Canada, to the best of my knowledge. Most of the time we have massive contracts with like Philips or GE Muse or Telemed or the other ones that are commonly used, at least in Alberta. That requires a lot of money. Somebody has to make a decision. As soon as they do, I'm out of a job reading ECGs. I got no problem. I read 8 hours a day on Fridays. It's a lot of ECGs to read and a lot of like confirm normal. And the computers could do it fast. And as y'all are taxpayers, right? You don't want to pay me to read an ECG when you can pay a software system once and then updates. Sure, one more question. I'm between you guys and lunch, so take all the time. Yeah.
My snarky question was, can an AI do an ECG? But can you talk about derived 12 leads?
Derived 12, like from the 6-lead thing that cardias do? I'm sure it would be able to analyze those as well. But you still have jobs putting stickers on and doing the ECGs and talking to patients. That stuff is not going to be replaced. But whether or not you might be able to manage, fewer people will run bigger labs, I would say. You won't need as many human persons processing things that we currently do. That's one of the biggest risks. I tried to skip over that. There's actually been a great study that I did not present today because it's definitely a downer for the Csct team that basically talks about complete replacement of cardiac techs. So, but we skipped that one today. We don't want to talk about that. Yeah, exactly. Drink up.
Well, thank you, Dr. Lockwood. I feel that transitions very well into my query in that with illustrating all of the incredible benefits that AI has the potential to offer, how do we weigh that with the inevitable consequences that range from misdiagnosis of a patient to the loss of thousands of people's livelihoods to the societal implications of the use of resources in fresh water and electricity for operating AI systems at this time?
That is a very valid point. So the largest use of power now in most of the world is actually the systems that are driving these. Like, they use incredible amounts of energy. There's like $1.5 million a year spent by ChatGPT because people say thank you. And it processes thank you at the end of your inquiry. So you ask it something and you say thank you. So it spends $1.5 million on power just for that. So that's a huge impact environmentally. I would say most governments don't care about the people, based on my opinion here, living in Alberta, in healthcare, and that they would be happy to replace us pretty quickly. So I don't think that's going to go very far. The errors, though, every study is going to show you the same thing. They're still better than humans. So as long as the AI is better than humans, radiologists have been making the same argument for decades. They're like, you can't let the computers read these things because we are better. It's like, no, you're not. You're not. And you get tired, and you're not reading it at 2 a.m. Those ECGs, every single one of those is interpreted in real time. So the emerge doc can make a decision based on that. The emerge doc is not the expert in the ECG reading, but they make a decision. The next day I get it in a pile of ECGs, and I'm like, shit, you missed like, that person had a heart attack, and you sent them home, right? So that would have been read by an AI system, told there's an infarct, and we would have managed it appropriately. So unfortunately, they are better, faster, they don't sleep, don't get tired, don't get distracted. But the problem is we still don't, as many of us have demonstrated, have the same level of trust yet in these systems because it is so new. And there will be problems, but it's the same thing with the self-driving cars. They're going to be better, even though all of us are like, I don't know, I'm a better driver. I'm like, I drove the QE2 yesterday. There wasn't a single person on there that's better than a computer, right? It is an awful highway to drive. Anybody have any other questions? Go ahead, fire away.
Just a quick one. You've outlined everything perfectly. What's your personal prediction when we're going to see boots on the ground AI in our environment?
Ooh, yeah, long time. I think those of you with gray hair, you're going to be fine to ride out your careers. If you don't have any gray hair, it may be a little bit riskier whether or not you've got it. Or you can adapt to it, right? So I think this is probably years away still. I still think we're within 10 years. I also thought self-driving cars would have been here if it wasn't for COVID, but not in Alberta, but in other places in Canada.
Quick question. So far, when we do ECGs, and most of them out there, you don't put in the demographics of patients, like what their background is, Asian, white, whatever. And so, how is AI when they say, oh, here's a predictor, but they haven't, you only have a birthday, how does that affect it?
EPIC is our electronic medical record or health record. Everybody's got one now, or you're going to get it, right? That'll be happening the first, and it just correlates it. So it takes that 9-digit number, your MRN or your ULI or whatever, and it just puts it in there. And in demographics, in our electronic medical record is your occupation, because I fill that in all the time. Your race can be in there, or they can guess it based on your last name with reasonable predictability. And then it can take your blood sample. Eventually we're going to have blood samples, or we might have your genotype. Anybody did 23andMe? Did anybody in here do 23andMe? I sent myself through it and my kid. I made sure he was mine. He looks just like me. It was easy. But it could tell me what kind of earwax I had based on my genotype. If I took that and gave it to an AI system, my whole gene listing, my God, the predictable power it would have would be incredible, right? It would tell you everything. It tells you which part of Europe most of my ancestors are from, and it's pretty neat. So, but we're not there yet. To answer the question, we're years away, but it is coming for us. And it's because ultimately it's going to come down to money, right? They can pay once for an AI system, or they can have, and if you could predict and keep people at hospital, right? So let's forget the money and the politics side. If you could say your risk of having heart failure, of worsening heart failure in the next 30 days is 10 times what it was a month ago, we need to intervene, get more Lasix on board, or get you in to see the dietitian to stop eating canned soups or whatever whatever interventions we can come up with, that would have a huge impact, because we could predict bad things are going to happen if we don't change something in our system, let alone the medications. I always think of the chemotherapies which people get that are like, wow, that was a swing and a miss. Wouldn't it be nice to not do so many swings and misses and maybe get them the right one the first time? So, anybody else? Any other questions? Lunch is all set up. I am just literally a barrier right now.
Thanks so much, Dr. Lockwood.
Appreciate it. Oh, thank you very much. Thank you very kindly.
All right, everyone, you're free to break for lunch. We will reconvene at 1 o'clock. Afternoon. Yes.
There's another sponsor?
Just so everybody's aware, we're going to start getting back into our session here in about 5 minutes, okay? Hi, guys. We're going to get started here. There's been a little bit of a change to our afternoon schedule. Dr. Chu was on service and unfortunately had to go into work today and do a procedure. So Dr. Ballantyne has offered to do both of his topics. So we're going to actually start with leadless pacemaking and then end with CSP, okay? So I will introduce Dr. Brennan Ballantyne. He is an electrophysiologist and advanced heart failure cardiologist in Calgary, Alberta at the Libin Cardiovascular Institute. He is also a clinical assistant professor at the University of Calgary. He completed fellowship training in both cardiac electrophysiology and arrhythmia and advanced heart failure and transplant cardiology. Dr. Ballantyne's clinical interests include the care of patients with heart failure and cardiac devices, optimization of cardiac resynchronization therapy, and cardiomyopathy and neuromuscular disease. His research interests include tricuspid regurgitation, cardiac devices, leadless pacing, and optimizing care for CIED patients with heart failure. Please help me welcome Dr. Ballantyne and enjoy his presentation on leadless cardiac pacing and CSP. So this is the clicker.
Oh,
brought a
perfect.
new one.
Okay.
So just kind of point it in that direction. If it gives you grief, he lends over there and she'll do it manually for you.
Can I see the slide? Oh, there. Yeah, perfect.
Do you want a computer up here with your slides?
No, that's fine.
You'll be okay.
Should be okay. Hi, everybody. Good afternoon. Sorry you have to put up with me for 2 hours. Dr. Chu's an excellent speaker, so I'll try and do some justice for him. He's actually dealing with some leadless pacemaker issues in the hospital right now, so kind of appropriate. You know, when I was asked to do this talk, my section was leadless pacemaking, a leadless pacemaker implant, and sort of some of the technology around it and some of the paradigm shifts that are coming for the world of pacing. I really just want to share my passion because I really like this topic, so I hope you will enjoy this. It's kind of a background in the development of leadless pacemakers, where we're at right now, and kind of what the frontier looks like and where we're going. And I hope, you know, I'll illustrate some cases and actually have some nice images in here, so hopefully it's an enjoyable talk. Does that work? Should I just manually? Oh, there we go. Thank you. So this is just a slide sort of to illustrate that Calgary is actually a site in Canada that holds quite is held in high regard when it comes to cardiac pacing and leadless pacemakers. We've implanted some of the first leadless pacemakers from various manufacturers. And we've done some really interesting cases. Dr. Exner is one of the electrophysiologists here who trained a lot of us in leadless pacemakers, and he's been involved with some of the research, some of the first implants, and is an excellent leader, but also a mentor when it comes to leadless pacemakers. Next slide. So just to go back a little bit, pacemakers date back all the way to the 1920s and 1930s. And at this point, pre-World War II, pacemakers were basically these hand-powered cranks that were powered by direct current electricity and could keep people alive for hours at the very most. Next slide, please. This is an illustration of one of the first pacemakers. So this is actually plugged in. It was plugged into a patient quite literally. There was a needle that was actually advanced through the sternum and tried, you know, to encounter the right atrium. And it was, as I said, hand-powered. And there was a direct current of electricity that was literally wired right to the heart. There wasn't a lot of uptake on this, obviously. You can see the quote there, an infernal machine that interferes with the will of God. This was sort of early, some of the thoughts about early innovation. There was a lot of pushback, and people just thought this was unnatural. Next slide, please. This is another sort of early pacemaker. Again, you can see that the electrodes were all surgically implanted or percutaneously implanted through people's chest. Next slide. And really, the cutting-edge development happened in Minneapolis, in Minnesota. So after World War II, we were starting to see a little bit more advancements in technology, and people were a bit open and a bit more progressive in how things were progressing in the field. And there was a surgeon at the University of Minnesota, a pediatric cardiologist, who had issues afterwards with complete heart block, which was common after some of the congenital surgeries. So he's trying to find a way to keep people alive and decrease mortality and morbidity. And he brought Earl Bakken, who at the time was an electrical engineer that worked with the hospital, into the fold. And Earl Bakken took this idea of a pacemaker to try and keep these people alive and ran with it. So we actually engineered the first external pacemaker out of a metronome. So recently, one of the innovations was an electric metronome that worked with electricity and had like a little speaker instead of the old mechanical metronome. So what he actually did was re-engineered this electric metronome to just tick back and forth, and he could turn up the speed or turn down the speed. And instead of it running an electric speaker, he had a current that piped into somebody's heart and actually ran the heart. So the impetus, the other kind of interesting part was the impetus for this was that in the age of direct current electricity, when they were just plugging all these pacemakers in, they had an issue, or as the story goes, they had a patient who died after a 3-hour power outage in Minneapolis, and they said, you know what, this is enough. We have to have alternating current and batteries and an external source basically for these patients. So this is the first generation of pacemaker. Next slide. And it sort of iterated and iterated over and over, and this is a little bit smaller, a little bit more user-friendly. Next slide. Until a group from Sweden actually created the first implantable pacemaker. So this was this epoxied pacemaker that was implanted by the group in Sweden, and then the technology was adopted eventually by the company Medtronic, that was founded by Earl Bakken. Next slide. And this goes to sort of show the difference between innovation, in the 1950s and 1960s compared to innovation now. This is how they created these devices. They actually used the mold out of this shoe polish can, and these were actually implanted in patients. So I think we've come a long way from our roots. Next slide. So I just show this slide to sort of impress upon you that now where we are is we have a lot of options for cardiac pacing. So since the development of implantable cardiac pacemakers, for generations or for decades, we've been using pacemakers that were generally implanted into the chest, usually in a pre-pectoral position, so under the skin, under the fat, but above the muscle. And then wires that are implanted into the axillary subclavian veins usually entered the heart, and that's the microphone or the antenna for the device, and that's how electricity gets to the heart. So the left upper square there is what we had been doing for a very, very long time, which is RV apical pacing, and then eventually RV septal pacing, trying to get something a little bit more natural to engage the natural wiring system of the heart. I'll get into this with Dr. Chu's talk in a little bit. Those other squares that say HB pacing and left LBBA pacing stand for His bundle pacing and left bundle branch area pacing. So this is the next sort of iteration of pacing. We tried, and I'll talk about this in the next talk, to figure out, what can we do to make pacing more natural? And the solution that operators have come up with over the years is to screw a little lead into the wiring system of the heart and engage the wiring system as naturally as possible. And the two places that we've done this is one, to screw a lead right into the His bundle, which is the first little area after the AV node in the heart's conduction system. And then the left bundle, LBBA, is left bundle branch area pacing, which is to screw a little lead into the area of the left bundle to engage the left bundle. So that still uses wires. It's kind of a step ahead because it's certainly more physiologic pacing, but it's still a wired technology, so it comes with all the same problems that transvenous pacemakers have, which I'll show you in a second. And then what we want to talk about today, or this session, is the leadless pacemakers, which takes away a lot of the complications related to transvenous devices. Next slide. So, just to set the stage for what problem we have with transvenous devices in general is, this is a slide showing the volume of pacemakers and defibrillators. You can see in the middle there, pacemakers and defibrillators. We have hundreds of thousands of these cases in Canada alone a year, and the implant volume is just going up year by year by year. So this is a technology that we use all the time, and any little incremental improvement that we can have in terms of the complications or success rates will really impact the healthcare system in general. Next slide, please. You can see it's just sort of tried to show you some figures about the estimated inpatient and outpatient costs of some of these devices. And you can see there's magnitudes of difference in doing these patients as an outpatient and doing these patients as an inpatient. And one of the implications of having to do them as an inpatient is they either present to a hospital with something that has happened or an acute problem that brought them to hospital to begin with, and they get the devices as an inpatient. But keeping them in hospital for days for complications mounts in terms of the cost of the system. You can see how expensive that is year over year. Next slide, please. And again, this is sort of the difference between the inpatient versus outpatient costs. That the square, that red square shows pacemakers and defibrillators, the costs, and the proportion of costs is shown between inpatient and outpatient. And that little bar at the top is the outpatient costs compared to the bigger, lighter bars, inpatient costs. So clearly, costs mount if you're number one doing these patients on an inpatient basis, and number two if you have complications that happen keeping these patients in hospital. Next slide. So what kind of complications are we talking about? Well, that's just an image of a transvenous pacemaker, and you can see that we deal with things like pocket infections from the pocket site, pocket erosions, bleeding, hematomas, or a big bruise that happens that sometimes needs evacuation where you actually drain the hematoma out. Hematoma by itself doubles, triples, quadruples in some case reports the instances of pocket infections. Putting these wires in, as I mentioned at the beginning, we put these wires into one of the veins in the upper extremity. And when you go after the axillary vein or the subclavian vein, we do so with a needle, and we guide our needle there either with an ultrasound or with fluoroscopy or chest x-ray. But the vein that we enter sits right over top of the lung. And the risk of pneumothorax when we used fluoroscopy to do this was about 1 or 2%. So not terribly high, but certainly when you see the volume of pacemakers that we put in Canada every year, that's a lot of patients that end up needing hospitalization for pneumothorax. And why I trained in a period where we were sort of transitioning from fluoroscopy, so I learned early in my fellowship how to access the vein under X-ray. And then later in my fellowship learned how to use ultrasound, and it's pretty scary actually how close the vein that you're trying to get into is to the lung. So you can really see in real time how this happens and how frequent it is. And then the other issues are obviously there's fibrosis and scar tissue and things like that develop along the course of the lead within the vein, and that's a big problem when you try and take these devices out. There's fairly significant morbidity and mortality associated with taking these devices out after 5 or 10 years or beyond. And then lower down, you can see that the wire itself can cause lead-related issues like tricuspid regurgitation. The wire can poke through the heart and cause perforation and cause issues with the sac around the heart. And then if somebody gets an infection outside of the area of the pocket, if somebody has a bloodstream infection because they go for dental surgery and it gets into their blood, or they have an infection in their leg that ends up developing bacteremia, there are some bugs that develop this film that just sits on those wires, and it's really, really hard to eradicate. So most patients need transvenous leads extracted, again, with fairly significant morbidity and mortality. So if you look at this, you think, well, what can we do about it? And the biggest things is eliminating the surgical implantation of the device and eliminating the wires. And that's kind of where leadless pacemakers are going. Next slide. Again, this I talked about this a little bit, but you can see the numbers of patients that are affected by this. So pneumothorax, depending on the technique, up to 3% of patients with pneumothorax. Pocket hematomas, depending on the patient. Patients are on blood thinners, or if they're on low molecular weight heparin, it can be up to 16% of patients that get a big hematoma. And then infections are not frequent, but you see there just under 1% to just over 3%. Infections for pacemakers that have leads or have wires are a very big deal. Next slide. So this is kind of, brings us to leadless pacemakers. That's the rationale for why we're using them. And these are the 3 available devices now. 2 that we've been using for a lot longer than the other. And I'll talk about the use cases for those as we go on. They're very small. They're a couple centimeters long. I'll show you how they're delivered. I'll show you where they're delivered. And they sit in the heart, fixed by different technologies. So some of them use these little tines, basically these little hooks that grab the trabeculations of the heart. So the heart on the inside isn't just like an egg, and it's not slippery. There's actually all these little trabeculae, or these little wrinkles, essentially, of muscle that these tines can grab onto and fix. And then another technology you can see there at the bottom, one of the other devices has a little screw mechanism that you actually put up to the interface between the blood and the muscle and slowly screw it in, and it stays in place like that. Next slide, please. This is how we deliver the pacemaker. So it's this really long sheath. We put it in the groin, so it goes in one of either the left or the right. We usually use the right because it's a little bit of a straighter shot up to the heart. But we access the vein, the femoral vein in the groin, and then we put a little wire into that, and then we dilate it up. And we dilate up to 27 French, which is like that. It's very big. I have small wrists, so it's probably like half the size of my wrist. So we just keep putting bigger and bigger sheaths in to dilate that vein up. And then eventually one of these introducer sheaths, or delivery catheters, goes up to the heart. There's a little mechanism on it that can deflect it, so it's deflectable. You can spin it around to turn the end of it. And then under X-ray, you find where your spot is, push it into that spot, and there's like a little lever, essentially, that you push that delivers it and separates the actual mechanism for delivery from the pacemaker. Check all your settings, and in the end, you just snip a little tether, like a little rope that keeps it there. And that's kind of the last, see you later. You got to make sure that you're really happy with it, because you have no way to pull that thing back in after you've delivered it. And you pull everything out of the body. And we have some little repair instruments now where you can add little sutures to that defect you've created in the vein, tighten the sutures up, snip them, they repair the vein, and the patient walks out of the operating room with looking like you've done nothing to them. They have a new pacemaker. It's pretty remarkable. Next slide. These are just the comparison of the options, and I show this just to sort of show you how big these things are, what they're made out of. So you can see they're a couple of centimeters, between 3 and 4 centimeters long. They're very thin. They're made out of a titanium alloy, which is what we use on other pacemakers. It's inert. The body doesn't react to it. It's actually what a lot of the space shuttle's made out of. And then the rest of everything there sort of just shows the differences between the two, which I've already kind of talked about. One is like an active fixation mechanism. One is passive. They are MRI conditional, so after 6 weeks, you can put patients through an MRI with no problem. And all of the devices now have the ability to maintain AV synchrony, which I'll talk about in a second. It's pretty cool, the different technologies that these devices use. Next slide. So the way that we sort of consider who we should be implanting these devices on and how the devices go in, as I said, there's a really, really big catheter that we put into the vein. Sometimes we have to put a temporary pacemaker up through the other side. So often we get access to both veins. We put a little wire up to the heart so that we can add heartbeats while we're doing this, because this catheter is so big that if you knock things around and you hit the wiring system or the conduction system of the heart and the patient has asystole, this is not, it's kind of an unwieldy thing. You can't get the pacemaker in the right spot very, very quickly, so you kind of have to have a backup option. So we often put a temporary pacemaker up and just take it out at the end of the case. These do not get infected. I put case reportable infection rates there because if they do get infected, you could report that case. It's so rare. There's lots of literature on patients who have these devices put in and then develop a really aggressive bacteremia, a bloodstream infection afterwards, and the device is fine. There's case series that of doctors that put these pacemakers in while the patient has an active infection, either intentionally or unintentionally, and the devices are fine. So that's a huge advantage, is the fact that they're pretty infection resistant. Most of the time we're doing these patients with deep sedation or conscious sedation, the same way you'd have a colonoscopy or tooth removed. There's no difference in the driving restriction compared to transvenous pacemakers. A couple of hours of bed rest afterwards is really all patients need. And you put a little suture, as I said, in the groin, or you put that suture that goes on the inside right on the vein, and that's really all you need for closure. The other kind of relevant part about this is to talk about why these devices don't get infected. And number one is because of what they're made out of. They're made of really, really inert material. But number two is the fact that they really don't have anywhere that's hidden from blood. One of the things about leads is they go through areas that have that can sometimes adhere to the walls of hearts or sort of hide from lots of blood washing. So when blood washes through things, it sort of minimizes the amount of this film that bacteria can hide in. That doesn't happen with leadless pacemakers. They're out in the middle of the heart and they're just washed all the time, so it's hard for these bugs to stick on them. So it's really an ideal technology for somebody who's at risk of infection. Next slide, please. These are recommendations for leadless pacemakers. Right now, we're really using, we have a lot of patients that we put leadless pacemakers in for, hopefully I haven't had too much caffeine. You guys can see that, right? You can see that, okay, good. I've had a lot of coffee this morning, so, okay, phew. Just want to check. The strongest reasons to put leadless pacemakers in, number one is a really high infection risk for some reason or another. Number two is vascular access issues. So if somebody does not have access to the blood vessels where we typically put wires in, we can't get a pacemaker in. So we would go from the groin and put a leadless pacemaker in. Number three is patients on dialysis, actually. If you're on dialysis, you need all the vascular access you can, all the vascular, basically any possible vascular access that somebody has, you need to maintain it, because these patients are always getting IVs. They've had AV fistulas. They're very medicalized, and they lose vascular access quite easily. So it's a really good indication, actually, for a leadless pacemaker. Next slide. Some less obvious contraindications, so patients we can't or don't think as much about leadless pacemakers. Morbid obesity is not necessarily a contraindication, but it's just harder. I have done patients with BMIs of, I think the highest was 58, which was recent. And it's tough because you need access to the groin, and there's lots of pannus or lots of tissue there, so you have to kind of spread things out of the way, and venous access is tricky. Patient has to lie on their back for a long period of time. This patient we ended up intubating because they had issues at lying that long on their back. Anyway, a little bit tricky, but those sorts of difficulties come with a surgical pocket in the chest as well. Patients have an IVC filter or device that protects them against clots that come from the legs. You just can't get through that with a catheter, so that's a problem. If you have a mechanical tricuspid valve, so a valve that's in the tricuspid position, that's the valve that we cross to get into the right ventricle. Can't cross you just cannot get across a mechanical tricuspid valve with really any leads, but definitely not a big 27 French catheter. And then some sort of size of the vein issues, tortuosity issues. This is makes this difficult but not impossible. I've had 90-year-olds that we've put these devices in, and actually one of my first cases was a really elderly lady, and her vein, instead of going straight up, which is what you see with most veins, it kind of did this, and it's really scary to see this big spear going like this through somebody's blood vessel, but she ended up doing completely fine. You have to use contrast. So if there's a contrast allergy, you might want to use a different pacemaker technology. And some elderly patients who had higher risk of RV perforation, especially elderly females, they have paper-thin right ventricles, and these are big catheters. So if you do perforate the ventricle, it's probably better to do it with a tiny transvenous lead than a huge 27 French catheter. So we're a little bit more hesitant, or at least we select patients a bit more for leadless pacemakers when they're elderly, and especially when they're females. Next slide. I'll skip this just for the sake of time. Next slide. This shows, this is just an example of one of the pivotal trials, one of the first trials putting in leadless pacemakers. And I'm pretty far away from the text, but I think this is freedom from complications, if I can remember. And you can see you want a straight line, essentially. You want everybody, 100% of people, to be free of complications after that. That'd be the ideal technology. That obviously doesn't happen, but you can see how shallow a drop that is and how high, close to 100% that is. This is one of the first trials as well, so it shows that even putting these pacemakers in for the first doctors who are doing this, for the first time this was ever done, this is a very successful technology. Next slide. Again, I believe this is lead trends. So this is basically just showing that just like transvenous leads, these are reliable devices. This is the electrical parameters from the device showing that the listening function of the device stays stable over time, the pacing function of the device stays stable over time, and some of the other electrical parameters stay stable. Next slide. There is some data, there's not a lot of head-to-head data comparing the two technologies, leadless technology versus transvenous technology, but there's been some trials, and the results are what you'd expect. Both had really high success rates of putting these devices in, but the leadless pacemakers had, as you'd expect, lower complications of pocket infections, of surgical complications, and complications related to the leads, because the leads don't exist in a leadless pacemaker. Next slide. This is just a survival from complications. So the line or the device that's better or does better in the trial is going to be higher up on that graph, and you can see the green leadless clearly is far and away better than the transvenous when it comes to complications. Next slide. This is another sort of way of demonstrating the amount of complications that the two devices have. And they both have complications. You are sort of trading one type of complication for another. You can see the leadless have more complications related to access. So if you're going to have a bleed from access, it's going to be because of that 27 French catheter, not a small little poke in one of the veins in the chest. But the big, tall red bars are really related to surgical complications when we do surgeries from the transvenous leads. So we minimize the risk of that happening with leadless pacemakers. Next slide. And this just shows, it's not just the short-term complications, but the intermediate-term complications as well that are lower in leadless pacemakers. Next slide. Next slide. I'm just belaboring the point here. And this is a real-world study. So the last study that I was showing data. It basically took patients and compared the pivotal trial versus leadless versus transvenous pacemakers that were put in for other reasons. And they took two of those populations, they matched them as much as they could, and they just compared them. This is actually real-world pacemaker data from both transvenous versus leadless pacemakers. So these now doctors putting in these pacemakers outside the trial. Sometimes the criticism is, well, if you look at trial data, these are doctors who have been trained to put the devices in during the trial. They're the best in the world. There's a handful of them. What happens in the real world? And this is a trial that, again, compared leadless pacemakers head-to-head compared to transvenous and showed very similar to the trial that there was a big difference in complications favoring leadless pacemakers. Next slide. Can't see. Next slide. There you go. The graphs are a lot easier. So leadless pacemakers, this one you want to, the group essentially that wins is going to be lower in this graph because this shows the amount of complications, not the freedom from complications. And you can see at 6 months, the leadless pacemakers definitely win. They have a lot lower complication compared to the transvenous pacemakers. Next slide. So, sort of wrapping up, I wanted to talk about a couple specific topics within leadless pacemakers and also just show you some cases. So maybe I'll go through a couple of interesting things about how these devices communicate and then some of the situations and the different patients that we put these pacemakers in. So first is AV synchrony. You can imagine with a transvenous device, you have one brain, like the device that's sitting in the left upper chest, and then you have the leads. One lead that goes in the right atrium, one lead that goes in the right ventricle, and those deliver electricity or sense, listen to what the heart is doing. And then the device itself has the brain and the computer to say, when should I be pacing, when should I be listening, and how do I make sure that the top and the bottom chamber communicate as well as they should, just like we're communicating naturally. And we figured that out, or the manufacturers of these devices over years have very, very sophisticated algorithms that they've essentially perfected. And now with this paradigm shift, you say, well, how are we going to mimic what we did with other devices, or mimic what the body does by synchronizing the top and the bottom chambers of the heart when you have this little pacemaker in there, and sometimes only one. Well, next slide, please. One way of doing that is an accelerometer. So this is the Medtronic device, and devices dating back years and years and years have an accelerometer, same way your phone does, to track how fast you're going or how much you're moving. So little movements, like little micro movements, are picked up by this accelerometer. And the idea behind the accelerometer is for rate response. So you don't want a pacemaker that just paces you at a programmed rate. You can imagine for some people that's fine. If you're 95 years old and you're in a nursing home and you're just laying in bed and you just don't want to die or pass out, or have some energy to just rest and to maintain the body's metabolic activity, you just need a heart rate of 50 or 60 beats per minute. But if you need to be active, you need to increase that. And if somebody is dependent on pacemaker, the way that the pacemaker does that is has a little piece of technology to determine whether you're active or not. And one of those pieces is an accelerometer. So the accelerometer actually tracks, okay, how much activity is this patient doing and how fast should I set their heart rate? And we can program that to be like a little bit more sensitive or less sensitive, and we can cap it out too. You don't want the pacemaker to pace the patient at 120 or 210 beats per minute or 200 beats per minute, so we develop a cap. But one of the sort of really cool things, almost a tangential use for this, is that accelerometer can actually listen to little perturbations that happen in the heart's pressure on the inside of the heart. So basically movement of blood through the heart, not only movement of the patient. And what we know from listening to the heart through stethoscope is that the heart has different heart sounds. There's lub, dub, there's like S1, S2, closure of the AV valves in the middle of the heart, closure of the pulmonic valve and the aortic valve, and then extra sounds that happen when blood moves through the heart. And that has to do with the electrical activity. The electrical activity happens first, and there's mechanical things that happen to the heart, like the contraction, the relaxation. So if you're trying to simulate the electrical activity, the kind of novel thing that this pacemaker does is say, well, why don't I just listen to mechanical changes in the heart, and I'm going to learn what electrical activity caused that mechanical change. Next slide. This is just sort of this is the cardiac cycle and the pressure changes that happen through the cardiac cycle. I just show this to show that it's, the things that start these pressure changes is electricity. The heart just doesn't do anything without the electrical system starting at first. Next slide. This is a little bit more detailed than one again. So next slide. I think I've got it better. Yeah, so this is what the device actually does, is that 1, 2, 3, 4 are the mechanical changes that the device picks up. You can see that like squiggly thing in the background. That's what the device is listening to all the time. It's like the noise in the background, but the device has been able to find different mechanical changes that happen, and they happen for real physiologic changes. They happen as the chambers are pumping and relaxing. And then if you look up, those changes, those mechanical changes happen after an electrical change has happened. So the device has been smart enough, or the engineers and the developers of the device have been smart enough to say, like, bingo, we got it. We have a way of being able to synchronize the heart based on what you think the electrical activity is doing. So the device has the capacity, by putting in one device, there's something called VDD pacing, which is basically being able to pace in the ventricle, but listen to the atria, listen to the top chamber of the heart. So it maintains AV synchrony. So you can listen to your heart rate, or listen to how fast your heart wants to beat, and then the pacemaker can hear that contraction that happens in the top chamber of the heart and say, oh, I just heard a contraction that happened in the top chamber of the heart. I'm going to deliver a pacing stimulus this long afterwards, because I know that what's coming afterwards is a stimulus that needs to happen in the ventricle. And if the patient has conduction disease or electrical disease, that's not going to happen. That's the whole reason for the pacemaker. It's kind of a cool way of getting through a problem with leadless pacemakers. Next slide. This is just sort of showing how. Don't worry about that. Next slide. Next slide. There are some limitations, so this isn't perfect. So this is very, very good when people have slower heart rates, but it tends to break down a little bit as people's heart rates go faster and faster and faster, is the bottom line. So you have less consistent AV synchrony with this type of technology the faster your heart rate, which for a lot of people isn't a problem. You know, a lot of the people in the population that we're dealing with pacemakers don't need a heart rate of 100, 120, 130 beats per minute. That's fine. So this is actually perfect, because at resting or at a little bit of a higher heart rate, you have very, very good AV synchrony, and patients do really well. But if you want that AV synchrony that's perfect, there's a different type of technology. Next slide. Don't worry about that. Next slide. There's a different type of technology where it gets around this problem in a completely different way. So another manufacturer's device, you put a device in the bottom chamber of the heart, and just like you would have two leads to listen to the top and the bottom chamber, you put a second device in the top chamber of the heart. So that bigger device is the one that goes in the ventricle. And then a very similar technique, you go up in the atria and you deliver the other device in the atria. And this is a study that looked at the AV synchrony, the success rates of this type of device. And since I made this presentation, this has already been published. So I think I added this in. Next slide. This was published in New England Journal of Medicine recently. Next slide. And this is the technology. So you can see you put a device in the bottom chamber of the heart, and you put a device in the in the top chamber of the heart, and the two devices communicate with each other and determine when to pace the top, when to pace the bottom, when to listen to the top, and when to listen to the bottom. Next slide. And pretty good outcomes. With different positions. This is a graph that shows how successful AV synchrony is. You can see you're at kind of 97. 98% of the time you're maintaining AV synchrony. So the top and the bottom chamber of the heart are working together. And this is at different heart rates and also with different positional changes. So they got these patients to lie down, sit up, move around, run around. And AV synchrony was really well maintained with this technology. Next slide. Another kind of interesting piece of technology that we're going to see more and more is something called modular ATP. Next slide. So this gets around trouble with this type of technology. So this is a subcutaneous ICD. So ICDs, just like pacemakers, have the Achilles heel that they go into a pocket in the chest. They have leads, wires that have to go into the heart. They get screwed into heart muscle. They have the same complications related to, or the same complications as pacemakers do. So this technology was developed where you actually put the generator or the batteries, the battery pack and the brains of the device kind of underneath the armpit. And you can either put it over top of muscle or between muscle. And then a little lead is tunneled. So you create a little tunnel. Basically, you have a spear, and you put it underneath the skin and the fat over top of the rib cage. And you create this little area, the surface area of the heart, so that you can listen to the heart and you can shock the heart if needed. So this is not extremely sophisticated. This is just a listening and shocking device. And this is called a subcutaneous ICD. So this is, we've been using this for a while, and it's mostly in younger patients where people have had a cardiac arrest, or they're very, very high risk of having a dangerous life-threatening heart arrhythmia. And you implant these devices to younger patients to save their life and to prevent them from dying suddenly, but you also avoid the complications from putting wires into their venous system. Next slide. And one of the uses of this ATP technology is to sort of solve a really big problem with that type of device. That type of device doesn't have the ability to deliver paced beats. So when people go into dangerous heart rhythm disturbances, you can do one of three things. You can listen, which a lot of the devices do. You listen for as long as programmed. And a lot of people go in and out of these rhythms and nothing happens. So you can listen for a little bit of time. But then the next thing you can do is you can actually add paced beats. So you can pace the heart really, really quickly, which is painless and often successful. And that's kind of the step before actually shocking the patient. So this type of technology has the ability to shock the patient, but doesn't have the ability to pace the patient. So this device manufacturer has developed a leadless pacemaker to be able to connect and work with the subcutaneous ICDs, so that if you put the devices in and they have these types of arrhythmia that would be really nice to be able to pace them out of, you can implant a leadless pacemaker to be able to add those extra heartbeats with this type of technology. Next slide. This is just a graphic showing chest X-ray. So that's a subcutaneous ICD, the subcutaneous ICD coil, and then you can see the arrow that's right in the middle of the heart. That's the leadless pacemaker that's connected to the subcutaneous ICD. So again, there's nothing in the vasculature other than that little pacemaker, and this patient has a very, very, very low risk of bloodstream infections because of the device or vascular complications related to the device. Next slide. This is just showing that they work, basically. Next slide. So I'll finish up with a couple of cool cases. I think they're cool cases. This is a 69-year-old female. She has symptomatic bradycardia because of slow atrial fibrillation. She has she has a history of rheumatic heart disease, and she's had a mechanical mitral valve replacement, and she's had a tricuspid valve annuloplasty. So she hasn't had her entire tricuspid valve replaced, but she has a little band that goes around the tricuspid valve that's taken the annulus, or the size of the tricuspid valve, and shrunk it because the tricuspid valve was so thick and dilated and had lots of tricuspid regurgitation. She had normal ejection fraction, and she basically presented for a pacemaker. And the problem with crossing the tricuspid valve crossing the tricuspid valve, as I mentioned before, with wires, is that you can cause problems with the valve. So in this case, number one, she had a mechanical valve already, and if mechanical valves get infected, it is a big deal. It's devastating. You have to reoperate. It's high morbidity and mortality. Surgeons hate it. So number one, we wanted a technology that had a low risk of infection. And number two, I believe we tried to get across the tricuspid valve with a wire. And a lot of these patients have really, really abnormal hearts. They have very, very big right atria, and then they have a very tiny tricuspid valve annulus because it's been banded. And it's really hard to deflect wires into the heart. Our wires usually just kind of flop right in, and they're designed to go into the heart easily. When people have this type of a heart, it often is very, very difficult. So I believe, if I remember this case, we actually tried to put a transvenous pacemaker in and failed. We tried a bunch of different ways. It was a case that took us like 3 or 4 hours just to put in a simple pacemaker. We were all really depressed afterwards. And we said, okay, we're going to book this patient for a leadless pacemaker. Let's see if this works. And it did. It was very, very successful. It was easier to get in across a tricuspid valve and to implant this lady with a leadless pacemaker. So it's a nice option. Next slide. This is, can't see very well. I don't know if there's a leadless pacemaker in there yet, or I bet you this is a picture of her heart. You can see how enlarged her heart is, and you can see silhouettes of the valve replacements is probably what I'm trying to show there is the right side of the heart. So the one that's on the left side of the screen is her right heart, and it's huge. It's very, very dilated, which sort of shows how difficult it is to get in. And you can also see the mechanical valve and the aortic valve, those little rings, those circles in the middle of the heart. That's what we were trying to get across. Next slide. This is a video, so you may have to press play, and hopefully it just loops back. I think if you hover over top of it, there's like usually a little play button at the bottom left. Or just click on the picture. Hopefully it works. Otherwise, that's a really boring picture. The other thing, can you go to play? Maybe you can go to presenter mode or the presentation mode and just bring up the slide and click the video. Yeah. Or maybe it didn't upload as a video. I'm sorry. I definitely have videos at the end, so maybe this is actually a still picture, and I'm just thinking it's a video. Anyway, this is, we can still go through the sequence of these things. So this is that catheter, that huge tube that's it's in the IVC, just under the heart, and we're just pushing the pacemaker out of that tube to get into the heart. So next picture. This is the tube up to the heart, and then the little catheter crossing the tricuspid valve. And you can see exactly when we cross. This is not what we see all the time, but this is really nice. You can see it going immediately across that tricuspid valve. So that's right in the middle. So you can actually see it crossing the tricuspid valve there. Next slide. This is kind of a head-on view. So you can see it coming out at you. It's like you're looking at it, and you can see the tricuspid valve there, and the device would be coming right at you in this view. Next slide. This is positioning within the right ventricle. Next slide. There we go, video. So what we do is we put this pacemaker into an area where we think we want to deliver it, and then we squirt a bunch of contrast. So it lights up everything around it. And what this is showing is we're not quite at the apex of the right ventricle. That's lower, kind of where the ventricle comes to a little triangle. What we want is to get it away from that area because that's very thin. And you can also see, you see when we squirt that contrast, how there are like ripples within it. That's not the contrast doing that, that's the heart. So that's all that trabeculated sort of ripply tissue that I was talking about at the beginning, and that's how we get these devices to stay. Is there's all those wrinkles there that we can deliver the device and it just hooks into those wrinkles. Next slide. Is a different view showing the septum. So this is the wall of the heart in the middle separating the two sides. And the way this view looks is that where the pacemaker is on the right side of the heart, squishing up against the septum. And on the right side of the image, kind of where that black mark is, would be the left side of the heart. So everything's flipped here. But this is showing a nice picture actually of how we find the septum or the wall in the heart and we just squish this pacemaker in and deliver it. Next slide. Oh, there we go. So you can see we're squirting some dye there and we're trying to deliver the pacemaker where we want it. Next slide. I don't know if this is a video or not, but this is how we deliver the pacemaker. So you actually undock it or undock it and leave it where we want it, and it's attached to these little tethers that still grab a hold of it. And we do all our testing to make sure it's in a good spot, and the electrical parameters of the device are good, and it's going to have really, really good thresholds, meaning it's not going to use a lot of energy to pace the heart, and it's going to last for years and years and years. And then once we're happy with that, we untether it, which is to basically cut the umbilical cord between the delivery system and the device and say, you're on your own. Next slide. And this is one of the tests with one of the types of devices that do a deflection test. You push it down, you push it up, and you just make sure it's in the right spot. Next slide. And then pull everything out, and that's what you're left with, is this leadless pacemaker, this tiny little device. Next slide. Next slide. Next slide. I'm really belaboring the different views here. This is a different type of device, and I believe this is a demonstration of how we take these devices out. So I didn't talk about that, but these aren't in there forever. Well, we put them in hoping they'll be there forever, but sometimes we either have to take them out or we have to upgrade them. And there are two options. Number one is take them out and extract the device completely, or number two is that they're so small we can actually find another spot in the heart to put a new device in. So you may actually have multiple of these devices. The younger the patient is, you kind of want to at least get one out and put one in. Otherwise, if you implanted a 30-year-old with one of these devices, by the time they're 70, the right ventricle is filled up with pacemakers and there's no room for blood anymore. This is an old device that had a recall on the device, basically, so they needed to be removed. And this is us taking one of these devices out. Next slide. That's the device. I don't know if this is a video or not. Next slide. Yep, it is. Next slide. Next slide. More views. There we go. So this is the capture mechanism. So there's a little retrieval mechanism. These devices all have this little button on the back of it. And you can go and just grab this button and suck this device back to the retrieval system, redock it, and pull it back out of the heart after. Some of the devices that have those little tines that don't have the fixation mechanism, you can just pull out a tissue. And the device that has a fixation mechanism, you actually have to counterclock or unscrew it out of the heart tissue. Next slide, or play, I guess. This is us trying to. This could take sometimes an hour, just sitting there, just trying to find where this button is. And you do different pictures, and there's other people in the operating room giving you suggestions, and eventually everybody's kind of cheering once you get it. Next slide. So this is when the cheer happened, probably. Yay! Finally, we can get out of the operating room. It's 7:30. I want to go home and eat. So we've captured the device. Next slide. And then you pull this device back in, as I said, and dock it. Next slide. And you suck it back into this protective sheath. Next slide. And you pull it out. I think this is the last case. This is just showing the two different devices. So one in the bottom chamber, one in the top chamber. And this is a patient, 32 years old, has congenital heart block. So he'd been followed for quite a while without a pacemaker. And we try with patients who have congenital heart block not to put in pacemakers unless they absolutely need to, because they have really, really good backup generators. They have really good junctional escapes. And the risk of them having something bad happen is very low. And they can also usually exercise and have the same sort of capacity as people who don't have congenital heart block. So you really only put them in if you need to. And this guy clearly in 2021 needed it. So he had a dual chamber pacemaker in 2011. So when he was 20 years old. And both his right atrial lead and his right ventricular lead are failing. Again, a problem that we want to avoid with transvenous leads. They don't last forever. Usually they last longer than this, but you can get 20, 30 years out of a lead, but eventually something breaks down when they move millions and millions of times in your body. And he was brought to the operating room yesterday, actually, for complex extraction. So we took wires out of him, and we put this new transvenous system in so that he wouldn't have any pocket up here with a scar, with a device. He wouldn't have any leads in his veins anymore, and he would just have this leadless system. Next slide. So this is kind of the last of the remnants of the right ventricular lead. So we've already taken out the right atrial lead. This is right ventricular lead, us just sucking it up. I think this is a video play. It's just like a straw up there. So it's a sheath that goes in and slurps up these leads essentially. And you can see eventually it's going to, I'm just pulling on it. Pull. Come on. Sometimes you pull pretty hard too, and then you suck it up. Yeah, there we go. Got it. Next slide. So we got all those leads out, and this is just showing the atrial system, because I've shown you a lot of pictures of ventricular systems. This is you can see the ventricular system there already. So we delivered the ventricular system, and this is the atrial system going in. So we squirt some dye. We try and find out where the atrial appendage is, and we place it at the base of the atrial appendage. Next slide. So this is just the device getting screwed into heart tissue and sitting there nicely. Next slide. And this is probably the last image, yeah. Next, perfect, yeah. So this is the two devices just hanging there, and top and bottom chamber of the heart, listening and communicating with each other nicely. That's about it. Thank you. Any questions?
Hi, it was a very wonderful presentation. Just question,
Yeah.
the PFO or the any septal defect would be a contraindication or helpful to like defect for
Very good question.
implantation?
Yeah. So I have not done anybody with a ventricular septal defect. I'd be a bit worried, to be honest. If they had a ventricular septal defect that was unrepaired, definitely complete contraindication. If you have a repaired ventricular septal defect, I'd be nervous. The place that we put these in is the septum, and one device screws in to muscle, and the other device, you need quite a bit, because you're on the septum and it's nice and safe, you actually put a lot of forward pressure. And these devices, you can find where you want to go. But a lot of the times the catheter takes you where it wants. And sometimes you have to really, really fight to put it in different spots. So depending, where the ventricular septal defect was repaired, I'd be quite nervous putting some of these devices in. I don't think it's a complete contraindication in patients who have repaired VSDs, but I personally have not done it, and I'm not sure that we've done it locally on anybody with a VSD repair. Now, the PFO is a really, really good question. It is not a contraindication, so we would put these into patients who have PFOs. However, you have to recognize that you're in the right chamber, because we found a leadless pacemaker in the left ventricle of somebody that had a PFO. And somebody had this either delivered inadvertently to the left ventricle, or it had migrated through the PFO after dislodging. It's not clear. But the patient showed up for a different procedure, and when they did the chest x-ray and looked, it was not in the right ventricle, and the only reason you didn't really know is because it had been pacing the heart ventricularly, just through the LV, not the RV. So the patient's really lucky, because the problem with putting something like that in if you're not anticoagulated is obviously the stroke risk, thrombosis on the device. So they didn't have a bad outcome, luckily, but that's one of the possibilities. So I wouldn't worry about putting it into somebody who has a PFO, but certainly you want to be very, very clear that it's in the right ventricle. And one of the ways on the ECG afterwards that you should be looking at is that they have a left bundle branch block. You have to have left bundle branch block because you're pacing from the right. So you have to make sure the electrical activity is going from the right side first to the left side, causing a left bundle branch block, showing that you're pacing on the right and not the left. I think this patient, in retrospect, when we look back, had a right bundle branch block, which should have made everybody a little bit nervous about where that device was.
Thank you so much.
Yeah.
Just wondering, cost comparison between the leadless pacing and the traditional?
Very good question. So it's much more expensive. The leadless pacemakers are, a pacemaker itself is really cheap technology, not because it's that it's not sophisticated. It's that there are a number of manufacturers that compete in the space, and it's been around for a very long time, so the costs have come down over time. So you're talking about a couple $1,000s for an entire system for a transvenous pacemaker, whereas you're talking about over $10,000 for a leadless pacemaker. Now, we don't have very good Canadian data yet. We're starting to get that, but there have been cost analyses from the US So a very different healthcare system, but it's been cost effective in the United States. You can imagine one sort of out of the blue example I can think of is somebody who has a pacemaker that's put in to get them out of hospital. And if you put a pacemaker in during their hospitalization, they can leave hospital after cardiac surgery. So we have a lot of patients who, after a valve replacement or a valve repair, develop a reason for pacing. And what we know about that is a lot of the time when we look at those patients in 6 months or a year in the device clinic, they're pacing 0% of the time. So the conduction system often wakes up, but we can't wait 3 months for it to wake up. We have to get them out of the hospital. So we often kind of bite the bullet and put a pacemaker in. Now, usually we put transvenous pacemakers in, but one of, as costs come down, you can imagine that putting some of these leadless pacemakers in, you could see that at the time that you see them in the device clinic in a year, and they're pacing 0% of the time, you can now remove that pacemaker quite easily. And the second thing is you've not developed complications related to the surgical site. You've not exposed them to venous complications, and you're not exposed them to the infectious risk of somebody who just had a valve implanted. So you want to make sure that they don't get an infection. So that's a long-winded answer to basically say we don't have very good Canadian data yet, but I suspect that in specific use cases, these will be cost-effective technologies. Whether they're cost-effective technologies for every single person, absolutely not right now. But as costs come down, they may be, especially when we look at cost analyses over decades, because certainly the costs mount of trying to extract these leads or deal with infections over time that come with the transvenous pacemakers. Okay.
Done a little break.
I think it's up to the audience. Yeah.
We'll let you sit down for a bit and then we'll bring up the next speaker. Sound good? Awesome. Okay. Alrighty. Well, thank you, Dr. Ballantyne. That was very good. We're just going to have somebody come up from Sean will introduce them, and then we'll start on with our last conversation of the day.
Okay, you ready? You go okay? Yeah, you grab the clicker. Okay. Okay, I just wanted to thank our gold level sponsor, the BCIT, for their support, and they are going to come up and tell you about their advanced cardiac programs. Really wanted to talk to our membership about it because you're the target market. So, Lisa Gowan.
Hello, I'm Lisa, and I feel like I'm the intermission for Dr. Ballantyne. So I will keep it short, but I'm here from BCIT, and if you're not familiar with our school, we have cardiac sciences, and we're from BC, and our programs are delivered online academically. And we do our clinical placements all over Canada, and that's for all of our programs. Our biggest program is the cardiology technology program, but we also have 3 advanced programs that I'm going to speak to you about today. So, of our 3 programs, we have the cardiac device specialty program, we have cardiovascular technology, and we have electrophysiology technology. So we're seeing our numbers grow a lot. Each year they're climbing a little bit more and a little bit more. I would say currently we have about 35 students across Canada in our various programs. The cardiac device is the biggest one that we have the most students in. And then next to that, they're probably about equal between the CV and the EP program. So I'm just going to speak to a little bit of the entrance requirements, and this is for the cardiac rhythm device program and the EP because they're the same. You have to do an English language proficiency test, or you have English 12 with a 67% mark. You have to have 2 years of allied health diploma or a relevant Bachelor of Science. We are a little bit flexible about the 2 years because many students do, if you come from our program, they do a significant clinical placement. And as sites are really eager to support employees that are in their department, there might be a little bit of flex with that. There's these 3 courses that have to be done, and those are done if you are a graduate from BCIT, but we also consider other accredited programs for entry as well. You have to have a letter of reference, and but the big piece, the difference between the advanced programs and our cardiology technology program is that students have to secure a clinical placement on their own ahead of being accepted into the program. So most of our students do work within cardiology departments, and it is their place of employment that supports them. It's not true for everybody. There's definitely other students that will be able to do a clinical placement in another facility, but a lot of them are people within their own department. So for CVT, the first ones are the same, and with the exception of the courses are a bit different. So the courses that you need for entrance requirement are a little bit different than the ones for cardiac rhythm and for EP. So this is what it would look like. This is the matrix. So if you are interested in the cardiac rhythm device advanced certificate, then these are the 5 courses that you would have to take. The ones in bold are ones that are embedded in our cardiology technology program. So if you're a graduate from our program, you would have already taken those 2 courses, which would leave you with the last 3 courses to have to take. 2 of those are academic, and 1 of those is a practicum, which is 625 hours. And our clinicals for the cardio tech program are pretty set. We do cohorts, but there's a lot more flexibility within the advanced because the numbers are smaller. So as long as it's mutually agreed upon between the site and the student, there's flexibility about when you start and what that looks like. One of the courses in this program too, the cardiac rhythm device follow-up, is sometimes done, students take that course while they're doing clinical. This is EP, so same thing, the bold ones are embedded in our cardio tech program, and then there's 3 other courses that need to be completed, and one of them, the bottom one, is 800 hours, and it is the EP clinical. So same thing, one of the courses, the 5520, the advanced, some students will take that course while they're doing the clinical. Some people find it very helpful to be able to do the academic and have the support of the preceptors on the site to be able to assist them with the coursework. For CV, we have the 3 courses that are taken already. So there's only actually 2 courses, but it's a monster. The 4370 is a big course. It's 6 credits. And the CVT practicum is 825 hours. So same kind of idea if it is agreed upon the site with the student when the student starts and stops. We do have some facilities that are supporting multiple students at a time, so they sort of self-schedule when they're going to be able to prepare to have their students do their clinical practicum. And that's it. So I just wanted to say thank you for having us, and thanks to the CSCT for doing this, because it's really been a big success. And I think what Crystal said earlier, it was taking a leap. And it's amazing sometimes when you're brave and you jump, things just work out great. So we're in the back if anybody has any questions, and I think one of my colleagues is going to populate the chat with our website if there's anybody that has wants to look up things on our website, and you can always reach out to us. There's the link to the Cardiac Sciences program, and thanks for having me.
All right. Well, his introduction was done last time, but we'll welcome again Brennan Ballantyne up to the podium here to talk about conduction system pacing.
All right. Back at it. The Blue Jays game just started, guys. I'm not sure if anybody's baseball fans, but I'm going to try to ignore my phone. But if I see people like having fun, I get it. That arrow. Okay. Thank you. So, as I said last time, Derek Chu is one of the electrophysiologists at the Libin Cardiovascular Institute, one of my colleagues, and he's on service this weekend. So unfortunately, he wasn't able to do this presentation. I sort of combined my slides from a different talk with his slides, and hopefully this works. Okay. Do I have to aim at something specific? Is this like I'm not a very good long distance shooter? Maybe. There we go. Okay, so this talk is about conduction system pacing. So different type of pacing. You need leads for this one for now. And the rationale, I just wanted to talk a little bit about CRT first, so cardiac resynchronization therapy, because that's most of the rationale for this thing called conduction system pacing. So to begin with, CRT is a technology we use mostly in patients with heart failure. And heart failure obviously has, as you all know, has a very high morbidity and mortality rate. The mortality slowly is improving, but it's not improving congruently. There's still lots of patients with different phenotypes of heart failure that do very, very poorly. You can see this data. This is a bit older data. It's US data. But it shows that the different lines are different areas or different spans of time, different decades, I believe. And even though the mortality rates are going down slowly over time, you can still see that the curves are very, very similar. And patients have very, very high morbidity and mortality rates with heart failure. Should I just do, let's do the next slide thing. Heart failure is characterized by acute deteriorations in a chronic disease state. And there was a study, this is a US study, I believe, that looked at patients who have heart failure and looked at the amount of times they're in hospital, and the median amount of hospitalizations over a short amount of time was 3. So these patients are hospitalized a lot. Next slide. There's a very high prevalence of heart failure. Depending on the study you look at, there's a prevalence of somewhere between 2 and 5% of the entire population that has heart failure at any given time. Next slide. And the prevalence is rising over time as well, and it's rising sort of incongruently as well. There are sex differences. There are phenotypic differences, but overall the prevalence of heart failure is rising, and it's becoming more of a problem, not less of a problem. Next slide. There's also a tsunami of different types of heart failure, and over the next several years or next decades, we're definitely going to see a different patient population of heart failure than we did the previous decades. Next slide. This is Canadian data, actually. There's a huge economic impact of heart failure. I already talked about the economic impact of pacemaker complications. Every year, we spend about $500 to $600 million on patients who have been admitted for heart failure. That's just heart failure admissions. That's not outpatient visits, medications, et cetera, et cetera. So it's a huge burden to the healthcare system. And by 2030, it's going to increase by 50%. And these are a little bit older numbers. I think this is like 2016 or 2018 data. So we're getting to a point where we're really starting to sort of take off in terms of the prevalence of heart failure and the burden on the system. So we need solutions. Next slide. So this thing called CRT is a solution for some patients with heart failure. And this is sort of the rationale for why we use this technology called CRT. there's early data on heart failure natural history that the QRS duration is an important role in sort of prognosticating patients or determining how sick they are with heart failure. The wider the QRS, the worse off their prognosis. And a QRS of greater than 120, so basically any abnormality in your QRS gives you an increase of 15% to your mortality risk with heart failure, so it's significant. That's totally independent of other things. That's independent of age, your ejection fraction, how clinically symptomatic you are, or the underlying etiology of heart failure. It's just the wider your QRS, the higher the risk you are. Next slide. And we think that's because of this rationale. So you have this thing called ventricular dyssynchrony. So about 1 in 4 patients have some sort of ventricular dyssynchrony when you have heart failure with reduced ejection fraction, so pumping function that is bad. That's added, this dyssynchrony is added to a number of other things that compromise people with heart failure. And this dyssynchrony is between the ventricles. So when you have intraventricular dyssynchrony, the right ventricle usually pumps milliseconds before the left ventricle, but it's enough that the ventricular tissue feels that. And then you also have intraventricular dyssynchrony, where the middle part of the ventricle pumps a little bit before the lateral part of the ventricle. So when the ventricles aren't synchronized, it basically changes the pressures on the inside of the heart. It changes the tissue characteristics of the heart. It changes the valve function of the heart, makes patients more symptomatic, puts you at risk of hospitalization, and puts you at risk of dying. So, you know, in the electrical sciences, the royal we, not me, but my predecessors have thought, well, can we do something about this? Can we correct electrical dyssynchrony, and will it make a difference to patients? Next slide. So this is a graphic of the heart. The right side is actually on the left, and the left side is actually on the right. And this is just color-coded for how early the activation is or how late the activation is in somebody who has typical ventricular dyssynchrony. And this is dyssynchrony from left bundle branch blocks. You have patients who have left bundle branch block. It's the most common problem with the electrical system when you have heart failure. And the reason for that is usually because the muscle itself is a problem, and the left ventricle isn't this wired structure. There's not one little wire that goes in to the heart and plugs it in. You actually have this like horsetail fan of wires that sort of spread out into the tissue, and that's how you pump this big muscular ventricle really, really quickly and synchronously, is that it's this diffuse sort of network of wires. And the wires are very, very connected with the heart muscle. So if you have a heart muscle disease, the wires are affected. So these patients get left bundle branch block. And the activation sequence is as you see that. So red is early and purple is late. So you can see that with left bundle branch block, the way the electricity gets from the top chamber to the bottom chamber is through the right bundle first. It activates the right bundle, or the right ventricle first, and then everything has to move from the right ventricle all the way across the heart over to the left ventricle. And the part that's activated the very last is this basal lateral area of the left ventricle, that purple area. So we've kind of thought, well, what happens if we add wires over there? And we add wires in multiple places of the heart, and we just control the heart's beat with our devices. And that's what CRT is. It's a way of trying to resynchronize the heart by capturing that really, really, really late activation area first, and like bringing the activation forward to normalize the activation of the heart. Next slide. So this is a normal ECG. This is somebody with normal sinus rhythm, and this is what happens when your ventricles pump together and synchronously. You can see how quick the activation of the heart is by looking at the QRS duration. So QRS duration, for all intents and purposes, is synchronous activation of both ventricles. So the narrower QRS, the more natural and synchronous the electrical activation of both ventricles is. Next slide. This is the left bundle branch block. So you can see how wide the QRS is. It takes a lot longer to get through muscle. And the things that are activated first are the right side of the heart. Leads V1 and V2 sit right here. And that's the place that sits right over top of the right side of the heart. So if you see big slurred S waves, things going, that electrical activity in V1, V2 is actually leaving the right side of the heart. That's the first thing that it does, is leave the right side of the heart. And if you see lead, if you look at lead V5, V6, but it's more obvious actually in lead 1 and AVL. Remember, 1 and AVL are lateral leads. They're over on the left side, and they're seeing things come towards it. So all you're seeing here is, number one, the QRS is wide. That reflects that it's taking a really long time to activate the heart. And the reason for that is dyssynchrony between the right and the left side of the heart. And number two, it shows the electrical activity starting on the right and then moving all the way over to the left, with that left lateral wall of the heart being activated last. And that causes, it is caused by heart failure, but also causes more heart failure. Like it begets more and more heart failure. It makes patients more symptomatic and accelerates the disease process. Next slide. So we put these CRT devices in, which is basically, this is a CRT-D, meaning a CRT defibrillator. So that thick wire in the right ventricle, the RV lead, has a coil on it. That's a ICD. So this has the capacity to shock the heart, because these patients are also at high risk of ventricular arrhythmia. But for the purposes of this talk, I'm just trying to highlight the fact that there are 3 leads there. One in the right atrium, that atrial lead, and then 2 in the bottom chambers of the heart, a right ventricular lead and an LV lead. And the LV lead is put into the coronary sinus, which is a vein, a structure on the back side of the heart. And the nice part about that is it wraps all the way around to the lateral left wall of the heart. So if we can get a wire into that, we can actually activate that the area that's being activated last when the heart is beating abnormally. And if you pace that first, we can resynchronize. That's the idea behind this, is the more areas you can pace, the more control of the heart's mechanical function you have. Next slide. This is the coronary sinus. So this is this big vein that wraps around the backside of the heart, and it has all these little branches, so you have all these options. And we squirt a little contrast into that, and we look at the map, and when Craig's in the operating room with me, we're usually trying to figure out which branch we should go in and where the sweet spot is, and usually you can kind of think about it for a long time, but sometimes you really only have one spot to go, and you just got to take what you're given. Next slide. And this is the venogram. So this is when you put a little contrast into that blood vessel, and you look at the branches that you have, and you try and put a wire way over and activate that side of the heart as early as you possibly can. Next slide. This is an activation map, basically, a color-coded map to see what areas of the heart are being activated first and what areas of the heart are being activated last. And on the left side, you can see exactly what we saw in that other diagram, where this is a before CRT. So this is somebody with heart failure, left bundle branch block, and you can see that there's areas that are being activated early and areas that are being activated late, and it's the left lateral wall that's being activated late. And after you put a CRT device in, and this actually has an arrow showing where that LV lead is placed, you can activate the heart more synchronously, and everything's sort of beating together. Next slide. So who, at this point, who gets CRT? And CRT is cardiac resynchronization therapy. It just means resynchronizing a dysynchronized heart with an electrical device. And I am very vague about that, because conduction system pacing, what we're going to talk about, is the next sort of wave of resynchronization. By not putting a wire in the back side of the heart, it's a different way of resynchronizing. So who gets this? Well, people have to have LV dysfunction. They have to have sick hearts or weak hearts. And generally, you have to have LV ejection fraction less than 35%. And usually, you have to have a wide QRS. You have to have, the wider the better, basically. And then there are other patients who also need resynchronization, which I'll talk to you about in a second. And we're learning a little bit more about these types of patients and why we need to resynchronize their heart. This is from Dr. Chu's slide, so I think he was trying to make a point that we sometimes do it just because. I guess we give CRT to patients who don't need it sometimes, is the point there. Next slide. This is a slide to show that not everybody responds to this therapy. So there are different groups of patients. There are super responders, people who have ejection fractions of 15%, are in hospital. They feel lousy. They can barely get up and walk around or cook something to eat. And then you put a CRT in, and 3 months later, their ejection fraction is 50. It's like back to normal. They're running a marathon, not actually, but you know, they're doing something incredible, and they've not been in hospital, and their kidneys are better, and they look better. That's a super responder. And then there's progressively less response to CRT. So there's a responder, somebody who's like, their ejection fraction has gotten better, they feel a little bit better, they haven't been in hospital, but they haven't quite normalized their ejection fraction. There's a non-progressor where, you know, have we halted the progression of their disease? Maybe. They're about the same a couple of years later, so maybe they would have been worse without CRT, but they're certainly not thriving. And then there are non-responders and negative responders, people who either have not responded at all and their disease is still getting worse or are doing worse with CRT. And these patients we know are some of the sickest patients in heart failure. I know from the other side of my job, the heart failure side, that if you look at all the types of heart failure patients, the patients who are lingering in the device clinic, who are non-responders for many years, they are some of the highest risk heart failure patients we have. They do very, very poorly. And it's probably, in my opinion, a combination of a couple things. One is the substrate, right? If they keep getting worse, they're not responding to medications, they're not responding to resynchronization therapy, they probably have a disease that is bad and is going to progress and be a very high risk. And the other is probably a systems issue, that there's electrical doctors like myself that are taking care of these patients by themselves and sometimes need a little bit of help from other doctors like myself, the other side of myself. So they need help from heart failure doctors, and these patients may need to be evaluated for mechanical support devices or transplant. Next slide, please. This shows that this is just sort of highlighting the fact that there's a big difference between responders of CRT and non-responders, and responders do poorly. Non-responders do poorly. There's a higher risk of ventricular arrhythmia in people who are non-responders to CRT. Next slide. Next slide. And then comparing patients who are non-responders of CRT compared to ICD. So somebody who has CRT compared to somebody who just has an ICD in. The people who are non-responders do worse. Like how that means that the CRT itself is either doing something bad in these non-responders, or we are selecting patients who are very, very, very sick. There shouldn't be a reason why somebody with an ICD compared to somebody with a CRT that's not responding has a difference. And the difference is probably, again, substrate, or the CRT is making things worse. Next slide. I'll talk about this in the next slide. So next slide. There's another reason to give somebody this thing called CRT. And one is something called pacing-induced cardiomyopathy. So pacemakers, of all the things we've already talked about, the complications from pacemakers, there's one thing that we didn't discuss, and that's something called pacing-induced cardiomyopathy. So heart muscle sickness and getting sick just from the pacing. And the reason for that is look at that diagram, and there are two wires there. There's one, the right side of that diagram. There's one wire that's the top kind of right side of that is a CRT wire, but where that other wire sits is where most of our leads go. And you can see that pacing from that site basically reproduces a left bundle branch block. It makes the heart have a left bundle branch block just by pacing. Remember last session when I was answering questions, we talked about the fact that you could tell where the pacing stimulus is based on the type of bundle branch block that the patient has on ECG. So if you have a right bundle branch block, you're pacing from the left. And if you have a left bundle branch block, you're pacing from the right. So right-sided pacing mimics a left bundle branch block. It makes the heart look like it's the way it would activate when it's really, really sick. And not everybody has a problem with this, but depending on the population of the study that you look at, there's probably somewhere between 4 at the lower end, maybe 3 or 4% of people, up to 15% of people that develop something called pacing-induced cardiomyopathy, heart muscle sickness because you're pacing, and that's it. They don't have anything wrong with them. They haven't had a heart attack. They haven't developed a cardiomyopathy for other reasons. Their heart is sick because you're pacing them abnormally. And when you turn the pacemaker off or pacing in a different way, their heart recovers. So that is one of the other reasons to say, well, some people who have had this pacing-induced cardiomyopathy need to be paced in a different way. And the way we do that is resynchronization therapy. We try and pace the heart as naturally as possible to eliminate that stimulus or that risk for pacing-induced cardiomyopathy. Next slide. So this is a patient. Oh, this is a case from yesterday, actually. This is a patient who we upgraded their device, a young patient, 32 years old, history of hypertrophic cardiomyopathy, LV dysfunction. His ejection fraction was like 15%. He had a pacemaker when he was young, a different patient than the other one I talked about, who had congenital heart block again. He had a pacemaker about 10 years ago when he was 20 years old, and he's been pacing all this time. And now we've uncovered a cardiomyopathy that isn't related to pacing, but we want to pace him more naturally because he has a big, wide left bundle branch block. So he got an upgrade to cardiac resynchronization therapy. Next slide. And all of this data comes from this study called BLOCK-HF. This is taking patients who have a little abnormality in their heart's pumping function, even minor. A normal heart, if you look at the echocardiogram, a normal heart is 52 to 55% or above is a normal ejection fraction. This randomized patients who had ejection fractions of less than 50. So some of them had ejection fraction of 48%, just barely abnormal, and said, what happens if we take these patients and we randomize them to either getting a traditional pacemaker or cardiac resynchronization therapy? What happens? Next slide. I just told you that. Next slide. And the difference was pretty dramatic, actually. The patients, this was a combined endpoint. So it was like dying from any reason, being hospitalized, developing heart failure symptoms, all these things brought together to have a primary endpoint. And the patients who had traditional pacemakers did worse. They had more of these events than people who had a cardiac resynchronization therapy pacemaker. So the bottom line is if you have any abnormality in the heart, any cardiomyopathy, no matter how mild, you can make that worse with a pacemaker. So that's what CRT is for some patients. Next slide. This is to sort of get to our next topic, which is conduction system pacing, to say we have lots of areas that we can pace the heart now. So number 5, I think that is, that wire that goes all the way out to the left side of the heart, that's traditional CRT, where we put something into the coronary sinus, wrap it around the back side of the heart, and pace from there. But there are 2 different approaches that we have now, one used a lot more than the other. Number 3 on that diagram is called His bundle pacing. I kind of talked about or alluded to that in the first talk. And what that is a wire that goes across the tricuspid valve into heart muscle, and it's screwed. And I'll show you the type of wire that we use. It's literally screwed or drilled into heart muscle until it engages the His bundle, the wire, going from top to bottom chamber of the heart. And it activates it, and it makes the heart beat as naturally as possible. There's some downsides to that. That's why we're not talking about that a lot. We're going to talk about a different type of conduction system pacing, and that's number 4. Number 4 is called left bundle branch area pacing, and that's putting a wire in an area that's close to the beginnings of the left bundle branch, the left bundle. And again, you're trying to, I talked to the patients about this, saying we're just trying to hot wire your heart. We're just trying to get a wire in there and hot wire your heart to restart the normal conduction system as much as possible. This thing called His bundle pacing was done a long time ago, but there's problems with the longevity of the wires. They tend to start to have really bad pacing capture thresholds, and the leads don't last forever. So this new thing that we do is called left bundle branch area pacing, and it seems to be more durable. Next slide. So this is to talk about this thing called conduction system pacing. It involves left bundle branch area pacing, LBBP, His bundle pacing, and then it sort of overlaps between these other things like left ventricular septal pacing and just different areas. But really, pure conduction system pacing is either this thing called His bundle pacing or left bundle branch area pacing. And you can see that the diagram has all the different places that we can sort of screw leads into the conduction system to hotwire it. Next slide. How does it work? If you think about the fact that when I was learning about this, and when I was in cardiology residency, and some of the EP electrophysiologists, like the fellows and the electrophysiology staff, were talking to me about this, it just doesn't make sense when you think about it. You think, well, if you've got a wire that's going into the left bundle, or the left side of the heart, your left bundle, and there's a block in it, how could you put a wire somewhere up top and hotwire that if it just doesn't work lower down? And the reason it works is because your conduction system doesn't work like that. It's not just a bunch of wires that go into the heart. The conduction system is a big wire, but it kind of works like fiber optics. So you have a huge wire, and through that wire is all little tiny wires. So your conduction system is actually what we call predestined. So you have the His bundle, and you have all these little wires that are predestined to go to different places in the heart. So if you screw something into that and hotwire it, you can actually engage the distal areas of that wiring system more effectively. Next slide. I think I already talked about this. Next slide. This is some early data just showing that we're probably having similar effects or similar successes when we use conduction system pacing compared to the traditional way of doing CRT with a conduction system pacing lead. This trial showed actually more benefit from left bundle branch area pacing compared to biventricular pacing or CRT pacing, traditional CRT pacing. But these are all very small trials. This is a really, really new technology. And we have big ongoing trials now that if somebody has very bad heart failure, I typically will start with the traditional approach and bail out to the new approach unless they're in a study. And if they're in a study, then they're randomized to one group or the other. And the reason for that is, look at this looks remarkable, right? The left bundle branch area pacing bar is higher than the biventricular pacing bar. Looks great, but look at the number of patients. I can't see very well, but I think it's like 40. So there's a tiny, tiny amount of patients in these trials. So we don't have a lot of data. We've been using CRT, the other type of CRT, for years. And we have thousands, at this point probably tens of thousands of patients who have been enrolled in trials, and we know how they do 5, 10, 15, 20 years out. Next slide. Next slide. Next slide. So how do we do this? So tools. Next slide. So the minimum requirements, as per Dr. Chu, is a lead. Obviously, you need a lead. And these leads you can see there are either lumenless, I mean they don't have a little tube in the middle, or they're stylet driven. So the stylet driven leads we use not as frequently, and you can put a little stylet, which is like this stiffener, basically. It just makes the lead a little bit more stiff and makes you be able to push it a bit more. And then there's lumenless leads that don't have the ability to do that. And how, in most patients, the way we do this is we deliver something called a sheath. So basically a straw, like this long straw that's sort of curved in a way that gets you right to the area that you want. And then you just push it right up against the heart muscle. And once you're there with that straw, you put the lead, the wire, through it. And then that wire hits myocardium or hits muscle. And you can see on the end of those devices, those little screws, you literally just sit there and you use your hands to drill this screw slowly, deeper and deeper and deeper into the septum. You just go on a drilling mission until you find where you want to go. And then we need some sort of recording system, because the way we get there is we map things electrically. That's how we find where we are. Next slide. These are the sheaths, so you can have these like sheaths that actually show you or get you to different places in the heart. Next slide. Again, they come in all these like fancy sizes and shapes, so you can use them to get to different areas. Next slide. More of them. Next slide. So positioning prep, so how we do this. Next slide. So we use a 12-lead system. So we actually get there by looking at electrical tracing. And that tells us exactly how far we have to go and whether we're going in the right direction. We sometimes modify V1, V2, V3, and we put them all on the right side of the sternum, and that just gives us more microphones to one particular lead. V1 is very, very important in this process. So by putting 3 leads over on the right side of the chest, it just gives you more microphones and a bigger area of view to pick up what you need to pick up. Next slide. So this is us crossing the tricuspid valve with our tools, and you can see that the HB is the His bundle. And literally that little, it's not intended to do this in this diagram, but it's probably pretty representative. That little circle is where you've got to be. You got to be in one little area, and if you miss it, game over. Speaking of a game, yeah, I'll look at that later. Never mind. 2-0 Jays. Oh, nice. Okay, great. Thank you. So the His bundle is this tiny little area, tiny little strike zone, and that's all you have to work with. It's very, very difficult to get at. Whereas that LBBA, that shaded area, is the area that you can go after where you're going to engage the left bundle branch area system. It's like expanding the strike zone, basically. You just have more to shoot at. So we cross the tricuspid valve, we turn our tools towards the septum, and we go after that area called the left bundle branch area. Next slide. And this is kind of more technical stuff as to where the catheters turn and how to position them. Next slide. Next slide. So this is, remember that view that I showed you of the leadless pacemakers that was showing the septum? And it was kind of looking from right to left, and it was showing the leadless pacemaker sort of screwing into the septum in one view. This is the exact same view. And this is the lead that's kind of taking this hockey stick-like angle and just screwing and drilling right into the septum. Next slide. This is I still need to trademark my cobra neck, is what I call it. Patent pending. Next slide. Next slide. So this is how we basically drill. We try and drill across tissue, but these are the sorts of situations that we get ourselves into that make it difficult. So you can actually, with this screw, get entangled into little pieces on the edge of the tissue. You can drill a bigger hole than you need, and the lead actually has a little bit more play and won't stay in the spot that you want. You can cause problems with the tricuspid valve apparatus. You could actually screw and grab the tricuspid valve apparatus, which would not be a good thing. And then you can also perforate. So you can go right through the septum. And weirdly enough, we perforate probably 1 in 5 cases, and we don't seem to have a problem if we do what's called a microperforation. So we always have these little screws that are crossing into the left side of the ventricle and perforating. And then we just screw them out and move on, and it doesn't seem to be a problem that we know about. But what we can't have, or what would be a problem, is macro perforation, when the entire lead crosses one side to the other. And this is the scary part conceptually when you think about this, like how could you just drill, and then if you go too far, you got a lead that crosses. Well, you know how far you're going, and you end up being able to stop when you just have a tiny, like less than a millimeter of screw into the left side of the ventricle. Next slide. This is how we find out where we are. So this is the BARD system. This is our mapping system. And basically, we look for a pattern like this, V1, which is showing up really poorly. It's in blue there. V1 in blue is basically a big downstroke. It's an S wave. And it basically looks like V1 in a left bundle. And if you remember, if you have a left bundle branch block, you're on the right side of the heart. This is what we look for. Number one is we look for that big left bundle look or pattern in V1 to say that we're on the right side of the heart. And we look for a couple of other patterns to tell us that we're on the septum and that we're not in other areas. And that is mostly from AVR and AVL being discordant. They're pointing to each other. And the look of lead 2 and lead 3, essentially. So there's some different patterns that tell us where we are and whether we should start. And this is the perfect spot to start. Next slide. And then as we move across the septum, we measure something called impedance, just the resistance essentially to electrical activity. And the impedance rises as you move across the septum, and then it falls. So that's how you know when you've perfed, when you've gone too far, is the impedance will drop really, really quickly because you've taken that lead or that screw that's in muscle and is moving through muscle, and eventually, and the resistance is rising to suddenly you have a very low impedance and you've popped through and you're in blood pool, basically. So your impedance drops. Next slide. So this is a slide sort of showing how we tell whether we're there yet. The beginning of this, the left side of the tracing, is the patient's normal rhythm. And then if you squint like me, if you look at V1, which is green, the middle section of V1 is showing that down, that S wave. So that's the beginning of the process. We're on the right side of the septum, and we're screwing. And eventually, towards the end of the tracing, you see what happens to V1? You develop this, what almost looks like right bundle branch pattern. You have an R prime. You've got a positive wave there. Well, that happens when you've moved far enough across the septum and you're on the left side of the septum. That's how you know, okay, we're close. We're definitely close to where we want to be, and we're on the left side of the septum, very close to left bundle branch block, or left bundle. Next slide. Along the way, we get these kind of cool things. They're called screw beats. So when we're close, we can actually like irritate the left bundle and cause these beats called screw beats that show that you're close. And it's just us actually knocking the left bundle to like knocking on the door before we screw all the way in. Next slide. And then we do something by measuring something called the LVAT. And the way we measure the reason we measure this thing called the LVAT is to measure the stimulation to the peak in V5 and V6. I remember I talked about this at the beginning a little bit, but V5 and V6 are left-sided leads. So they're going to get positive when you're moving from right to left. And if you pace and you're in the left bundle, you're going to have to go down the left bundle all the way through the His-Purkinje system, all the way out to the left side of the heart. And if you are not in the left bundle, the way you get there to the left side of the heart is through the septum, just septal muscle. So you have to go all the way through muscle, all the way down the septum, all the way through the left ventricle, and all the way out to the lateral wall of the left ventricle. So your duration, or how long it takes, if you are not in the conduction system, is going to be quite long from the pace to the peak of V5, V6. It's basically a measurement of how quickly you're getting the left side of the heart. When you measure this thing called the LVAT and it shortens, you can tell yourself that if it's really, really short, the only way it could be short is if you're engaging a wire that's hot wiring yourself all the way over to the left side of the heart first, and that's the normal conduction system of the heart. So we actually measure this measurement, and we do it every single little screw we do, and the closer we get, the shorter and shorter and shorter the LVAT until you have this jump in LVAT because you engage the wire that gets you all the way over the left side of the heart. Next slide. The other thing we measure is this thing called the interpeak distance. So if you measure V5, V6, the peak in V5, V6, which is the left side of the heart, compared to the peak in V1 and V2, which is measuring the right side of the heart, the farther apart they are, the more likely you are in the conduction system. And the reason for that is if you're in the conduction system, you're getting all the way over to the left side of the heart first before you get over to the right side of the heart. If they're together, if they're close together and that distance is short, you're actually just in the muscle, and your electrical activity is going all the way through septal muscle and then spreading out to one side of the heart and to the other side of the heart equally. Hopefully that makes sense. Next slide. This is small and difficult to see, but basically this is, if you could record this, which in the future we will, we've got little options, and the companies are coming out with little adapters where you can listen to this screwing, the electrical activity as we screw all the time. Right now we're sitting here like this, screwing, plugging something in, listening and doing some testing, taking it off, screwing it, and just doing this over and over and over. Soon we'll have an adapter where you could leave it on the end of the lead and just sit there and drill and watch something like this happening in front of our eyes and see the electrical activity progressing and changing to a point where we get to our endpoint and we stop. Next slide. And this slide shows on the left, it's a fluoro image. There's a number of different ways to tell us whether we're in the right spot, which I just explained a couple of them. But the last thing you can do, and this just I just think that this is interesting because it shows how deep in the septum you are. This is a contrast injection through the sheath, so that straw that we use. You just squirt some contrast, and it shows the edge of the muscle, and you can see how deep that lead is into muscle. That's what we're doing. We're drilling into muscle by, several millimeters. Next slide. And this is kind of the final result. So if you're looking at ECGs and somebody has a pacemaker, you can clearly see a pacing spike, but you don't see a left bundle branch block, and you think, oh boy, like could this be like that case we talked about where you've got a lead across a PFO or through the septum, and you're pacing through a VSD, and you're actually pacing the right side of the heart? That's a possibility. That still is a possibility, but more often than not now, this ECG is conduction system pacing. So you have a wire in the septum, you're into the left bundle branch, and you're engaging the left side of the heart a little bit before the right side of the heart. And compared to that ECG that I showed earlier that had a big wide left bundle, this QRS duration is narrow. It's 110, 115 milliseconds. You have a little RSR prime in V1, which kind of looks like a complete or incomplete right bundle branch block. And you have really, really quick depolarization, like really sharp QRS morphologies. And that just shows that you're activating muscle, you're activating the heart synchronously and very, very quickly. So this is something that you're going to see more and more that is conduction system pacing, and this is a perfect example of a left bundle branch area pacing device. And this is pacing the heart more naturally, but is also an option for CRT. So you can see how if somebody has a left bundle and you want to correct it, instead of putting coronary sinus lead down, you could do this type of technique, hot wire the heart, and this is the result you get. I think that's it. Can't remember. Next slide. Yeah, that's all. That's all Dr. Chu gave me. Any questions?
So I guess there's no point in doing a magnet check on these people because we're not going to see any real change in that morphology, are we? Because of where the lead placement is?
Oh, do you mean for...
After they put, like, sometimes we get people in and we don't actually know they've had that type of pacing put in. We're going like, it's not working, like it's not looking like a left bundle branch pattern. So that would never change, right?
You would still, the morphology would not change, but you'd still have the same magnet function through the device. Okay. So you'd still have that rate change that you get with magnet mode, but you wouldn't have the morphology change. Yeah, you wouldn't have a morphology change. What you will sometimes see is depending on the programming of the pacemaker, you can lose that conduction system pacing morphology. And the reason for that is complex, but if you ever see somebody whose ECG one day or 1 hour or 1 minute before had a look that was not conduction system pacing, and then the next minute was conduction system pacing, the device actually may be going through an auto capture feature. So all the devices, you know, are programmed depending on the manufacturer and the device to check the capture threshold, just to make sure it's stable at different times of the day. And one of the things about conduction system pacing is that at high outputs, you may actually be capturing muscle around the conduction system plus the conduction system. We call that non-selective capture, meaning that you're capturing the septum plus the wires. So the morphology will look a little bit different. But as we see this all the time when we're in the operating room, we test the threshold of the device by bringing the energy level down. And at some point, you actually go from this non-selective look to selective because you don't have enough energy to capture the muscle, but you still have enough energy to capture the conduction system. And when you see differences on ECGs from 1 minute to the other, it could be that the device is doing an auto capture, and with one capture threshold, you have conduction system pacing, and the next auto capture threshold, you don't. So we often know when we have somebody who is not pacemaker dependent, and they have very good electrical parameters, we often turn auto capture algorithms off so that we don't do that. And the other thing is often we have this, when we set up a device, we want a window of safety or a margin for safety. We say, we can capture myocardium at a volt or less. So we lose capture at a volt. Let's say that. So everything less than a volt, we cannot capture the heart. Everything greater than a volt, we can. But you don't want to set your device right at a volt, because if things change, you could lose capture. So there's always a margin for safety. So we may say, let's set the device at 3 volts, just to be safe. When you do that, you have to be very safe that you are not now losing the ability to capture only the conduction system, because if somebody needs resynchronization, they need this device to only capture the conduction system, you could send them away and see them back in 6 months and say that entire time they've not been getting better because they've had a normal pacemaker and not a resynchronization device.
Last question. So we've found now, I don't know if it's any particular type of pacemaker, but we have to wait that they've been out of the OR at least 20 minutes or we will not get magnet capture. Why is that?
For conduction system?
Like they've come out of the OR and we will put a magnet, do a 12 lead without magnet and with, and it won't change into magnet mode, that pacemaker. And so now we're waiting 20 minutes and it will.
I don't know. Ask Medtronic. Implant detect mode. I did not know that. Thank you.
Does different type of cardiomyopathy have any role in choosing the CRT?
Sorry, say that again.
Different type of cardiomyopathy.
Good question. Like, are we choosing different types of CRT for different patients with cardiomyopathies?
Yeah.
We don't know. That's the short answer. Is we're still learning which type is better for which patients. And the way the trials have been designed, it's kind of a catch-all. Fortunately and unfortunately, we'll get a lot of data about a lot of different types of patients, but we probably won't know for a very long time who to use the various approaches for different patients. And I already sort of know anecdotally that patients who have really advanced diseases or have had ischemic cardiomyopathy and have had a septal infarct, like they've had an anterior myocardial infarction and they've got a scar on their septum, they're very, very tough to get very good outcomes with this type of conduction system pacing because you're screwing a lead into the septum. And with really advanced cardiomyopathy, same thing. They have really, really fibrotic and thick hearts. So it's hard to screw a lead in. So I think personally, at some point, we will have those answers. But right now, if somebody has an advanced cardiomyopathy or they have a really bad ischemic cardiomyopathy, I would much rather have a standard CRT compared to conduction system pacing. Whereas somebody who has non-ischemic cardiomyopathy early in the disease state is like the perfect type of patient who's going to be a super responder to conduction system pacing.
Right. And one more question. When we start screwing up, so the first changes we'll see in lead 1 and AVR, and then probably it will be V5 and V6.
Yes.
So are we also expecting the same changes in V1 and V2 together with lead 5 and V6, or it will be little delayed?
No, you're right. So all the leads change, but where your eyes focus because of what you're looking for is exactly what you said. At the beginning, I'm kind of looking at V1, AVR, AVL to know I'm in a good spot. But then you're looking at V5, V6 as you progress to see that peak is getting sharper and it's getting closer to the stimulus. The other thing is kind of cool, which I didn't show an example of, but you can clearly see on electrical tracing when you have a stimulus and then you have an isoelectric period where there's no activity, and then you have the QRS, you know you're in the conduction system. And the reason for that is you stimulate, you send the electrical activity, it gets into the conduction system, which is an insulated wire, basically. Right. So there's this period of time where you have no myocardial contraction until it exits that insulated wire into heart tissue and then gives you your QRS. But if you are in tissue that is not the conduction system, you'll actually have this little slur part at the beginning that is myocardial or muscle capture first before getting into the conduction system. So that's the other thing you're looking at with your eyes to show the difference between being in the conduction system and not being in the conduction system.
Thank you.
Yeah. We're going to let him go home. He's losing my voice.
Awesome. Well, thank you very much, Vernon.
So thank you, everyone.
This is for you. Thank you.
If everybody can just hang around for a couple more minutes, Crystal just has some closing remarks. Thank you very much, Dr. Ballantyne.
All right. As we wrap up our Education Day, I want to extend a thank you to everybody who made today possible. To our incredible speakers, thank you for sharing your knowledge, insight, and expertise. Yes, we did have a couple technical difficulties and hiccups, but what is a virtual event without "where are my slides? Can you hear me?" But thank you to our AV company for quickly jumping in and fixing everything. We appreciate your patience and good humor and flexibility. It has been all a part of our adventure. And hey, just think of this, we're making history together. A huge shout out to our sponsors. Thank you for spending the day with us and letting us all visit your tables and learn everything that you had to offer. I'd like to take a moment to recognize who made today possible, the Board of Directors. I'm going to get them all to come up one by one. We have Alin, our Alberta Director, Lauren, our Saskatchewan Director, Linda, our Manitoba Director, Christina, our Ontario Director, Valerie, our New Brunswick Director, Michaela, our New Brunswick PEI Director, Megan, Newfoundland and Labrador, Emily, Director at Large, Gretchen, Secretary, our Executive, Sean, VP and BC Director, April, Treasurer, Jessica, Education Director, and myself, your President. And Cheryl, our registrar. We're going to all move back in. They're going to get a picture shortly. Move in there, guys. Squish in. No, we'll wait for the picture after. Hang on, picture after. I'm just going to keep talking for 1 second. I also want to thank Trinity, who is not able to be here today, but she is joining us virtually. So wherever you are, Trinity, thank you. Trinity was a big part of our organizing committee. She is from our Alberta Association. Most importantly, thank you. Thank you for joining us, spending the day with us. Your engagement, your energy has made this day possible. Today, we didn't just host an education day, we launched something new for our profession. And this, it's just the beginning. For our virtual guests, thank you, and we will see you tomorrow during the AGM. For those attending in person, we know lunch was a character-building experience, and we hear you. And we promise, as our committee told me, our dinner will be much better. Plus, we got surprises, gifts, and something else stored away from you. So remember, cocktails start at 6 p.m., and I expect you to all have your dancing boots on. Thank you.
Right now?
Yeah. Where are you going, Sean?
Oh, and don't move. We're taking a picture of you guys as well. Can you guys come in?
No. Cheryl, you're short. You're going up there.